The effects of this limited available provider network has resulted in emergency rooms overloaded with psychiatric patients who have previously been maintained in the community but have deteriorated because there are no resources left for them to access. Unfortunately, the majority of these patients will end up in state hospitals, ultimately returning to communities that lack the basic resources to maintain them. Our healthcare system is also stressed by shifting of costs to other providers. As I mentioned above, our emergency rooms are in a crisis situation dealing with psychiatric patients who have not received community resources. This issue impacts not only hospital ERs, but the cost shift is directly affecting our state hospitals. And you might ask, well, how is this occurring? As you will see in the examples that I've provided, the CMO criteria for admission into treatment are a moving target. It's consistently altered to meet the needs of the CMO, not the patient. It appears to be almost premeditated in order to deny access for members, create obstacles and roadblocks for providers with treatment denials and ridiculous utilization requirements, ultimately not paying providers or tremendous delays in payment, or ultimately denial what I would consider to be clean claims, which will eventually and effectively close down resources without significant financial stamina. The infrastructure of community-based mental health resources in our state is weak, it's crumbling, and in lots of counties it has disappeared altogether. Finally, I'm extremely embarrassed to share with you just a few comments that representatives from the CMOs have used with me or my staff regarding patients of ours. Yes, it's clinically appropriate, but we don't have to. It's not our responsibility to fix George's problems, or he needs to be thrown into a black hole somewhere and never get out. Well, I'm sure the professional who made the final statement may be frustrated due to limitations that have been placed on them by those higher in authority in the CMOs. It is extremely sad that their option for treatment is to throw somebody in a black hole and leave them somewhere. The end result of these examples has been an increase in obstacles which interfere in a provider's ability to offer care to this vulnerable population. In fact, I've had to hire, like the gentleman here, 4 staff this year just to handle the burden that's been placed on our system by the CMOs. I've enclosed attachments illustrating how, in my opinion, the CMOs have potentially violated their contractual obligations to our government and ultimately the citizens of our state. It's really hard to understand how the system is fair for Georgians. How is it fair that one section of the Medicaid population is receiving care under fee-for-service contract can receive appropriate care, but those who are covered by CMOs must risk their life and sometimes just to get their needs met? How can we work with companies who respond to us, yes, it's clinically appropriate, but we don't have to, and it's not our responsibility to fix the problems of Georgia? These are children we're talking about, our children. Given all these issues, we strongly urge you to respond to this need immediately to address the lack of access to care, the shifting of costs to other providers, and the unprofessional culture. I want to thank you for your time and the opportunity to be a voice for a truly desperate group of Georgians. Thank you.
Representative Hinton has a question.
Thank you for your testimony. Beside the fact that you're probably losing money because of lower fees and everything else, approximately how much money did it cost you to add this for additional staff people?
It will cost, when you look at benefits and everything else, somewhere around $150,000 a year.
Thank you.
Thank you.
Ingrid Jensen.
Good afternoon. I appreciate the opportunity to make my voice heard. I'm Ingrid Jensen, and I work as a service coordinator, or as commonly known as case manager, with early intervention in Augusta, Georgia. I heard this morning over the monitor that CMOs now have case managers for all the children from 3 years and under. I would really like to see a job description of those case managers. Excuse me, I'm nervous. But I just want to give you some idea on what we as the case managers out in the fields are required to do and what we love to do. We service coordinators, we have monthly home visits anywhere from 30 minutes to an hour and a half. Now the purpose of these visits is to follow up on the goal development, and which means have the children progressed, obtain information what is going on during the past months. Are there any special problems which have a direct impact on a child's development? Families can have a large variety of problems requiring intervention. Family counseling in child-rearing practices is often needed. The most mundane problems can seem like an overwhelming task to some caretakers. Service coordinators also provide financial and counseling, helping with transportation, assisting in obtaining child care, making sure that children get nutritious meals and live in a clean home. And we are required by the law to notify defects if a child is in an unsafe environment. In addition to these duties, we also have a lot of paperwork to carry. We all work from a plan that is developed by all the service providers in the family. We work off these plans, check the goals, the revised goals as they're being met. We have a 6-month plan review with the team, and each year we have to do a new plan. And when a child is 30 months old, we start a new line which is called transition, is when a child is being evaluated by the school system if further intervention is required. This means that the school system will come out and do a screening to make the determination whether the child will require further intervention, and we are with the family and we provide help so to make sure that no child is left behind, which was a great slogan at one time. I had a 2-month-old boy who was referred with a diagnosis of hydroencephaly. His head was enormous. He experienced daily seizures, a variety of symptoms to include temper tantrums, short attention span, etc. The doctors gave him about 6 months to live. After 1 year of therapy and services, he was able to keep his head at midline. At 2 years, he was able to sit. His locomotion was rolling along the floor, and he got around pretty well, surprisingly. He learned to manipulate toys, follow simple commands, attempt to sign words. Every time he had a surgery, he experienced another setback of at least 3 months. Now the CMOs are coming in, and everything has changed last year. AmeriGroup finally agreed to pay some of our fees for the service coordination. However, they never did. I don't know how many times I applied and never found my paperwork, and so did many other people in my position. And so a lot of us gave up trying to get listed as a provider. AmeriGroup owes me at least $5,000, which may not sound a lot with the millions of dollars here, but it's a lot of money for me working for myself. So now it seems that the CMOs want to provide service coordination from their offices. I cannot imagine how they provide service coordinator as is customary under babies can wait. I also cannot imagine that a monthly phone call, if they're lucky, can be as effective as we provide service coordination. I love this program and the children's and the difference we make in a child's life. Please keep Babies Can't Wait as it is now. And thank you very much for any help you can give us.
Thank you. Dr. George Bugg.
Good afternoon, and thank you. I'm Dr. George Bugg, a pediatrician here in the Atlanta area, and I'm concerned about the metrics or the measures that you're getting about the success of the CMOs, because that's not the success that I see. I think sometimes when you have a meter, perhaps it's measuring the wrong thing or just not accurate. If your car says you're going 30 miles an hour, you're looking in your rearview mirror, and that Georgia sea turtle is catching you, something's wrong with your meter. I think if you look at the Medicaid program, you look at the expenditures that it was providing to children over a period of several months before the CMOs came into place. Look at the same measure of the split between the traditional Medicaid and the CMOs after that came into place and see how much money was actually paid out. You'll see the effect of the drop in payments to providers. I know personally that Peach State was having several months before it could pay a claim, and that never showed up on the metrics that were put out by the state. You could also look at the monthly average OB patients that were paid out for over time when they came into place, because I know that many OB providers had significant trouble getting paid. One of the major issues has been the paperwork involved in getting care for patients. A mother of twins that I cared for in the Wade nursery down the street came back for a follow-up visit, and she told me that one of her twins had gotten very sick that last winter. The other twin, fortunately, didn't get as ill. Both of them had the same disease that can be ameliorated or made not as severe by getting a monthly injection during the RSV season. It seems that the CMO approved the paperwork for one of the twins and didn't for the other. And you can imagine which one got sick, the one that didn't get care. Here in Atlanta, they talk about being in an urban area. Well, I can tell you it's very difficult to find a pediatric orthopedist here in Atlanta that accepts any of the CMOs. They've had a very difficult time enrolling them, or so they say, but it's very difficult for us to get care for children who have things like a club foot. It needs to be casted. I know the concepts of it. You need to cast it, continue to cast it until the foot becomes flat again and the kid can walk and run and play. But I understand the principle, but I can't do it. I need a pediatric orthopedist to do it. And here in the Atlanta area, I think there's maybe one group that can do it. And one group can't see all kids. The same thing for pediatric ophthalmology. I would just end by saying that also looking at it from the appropriation standpoint, you think about how much money is being spent, but also think about the care that's given and whether or not the amount that's being given approaches the cost of care. The cost of care has risen in large part because of the paperwork that's required to keep up with all the changes that are going on among these three different entities. So the cost of care has gone up because of that end. And also, at the beginning, I don't know that we were really adequately reimbursed for the cost of care given. So somewhere along the lines, the government needs to look at the cost of care that's being provided and seeing how close these appropriations come to that. Thank you.
Thank you. Pat and Paul Davis.
I'm Pat Davis, a pediatric physical therapist for 36 years and part owner of a physical therapy practice in Augusta, Georgia. I'm going to change much of what I was going to say because so much of it has already been mentioned. But I just want to reiterate this if you haven't gotten this point yet. Families are suffering. Children with special needs are suffering. It's hard enough to come home from the hospital with a new infant. But to come home from the hospital with an infant that has special needs, and all of a sudden you have to fight for every kind of care that you want because medical people in the state of Georgia are not being paid correctly because of the prior approval process. That is a literal nightmare. because no matter how many times a skilled therapist, a licensed therapist that the state of Georgia has licensed, sends in all their reports, documents everything, a pediatrician or a pediatric neurologist signs and approves everything that the therapist is submitting for a prior approval, and the CMO has the right to come back and say, you medical people don't get it right. WellCare has come back now with a new policy that physical therapy will be approved only 2 times a month, so that any child over the age of 3, our physical therapy practice is discharged. And so many pediatric physical, occupational, and speech therapists in the Augusta and surrounding areas have resigned. They no longer treat children because they couldn't get paid. No child over the age of 3 in the Augusta area can just go into a place and get physical therapy. The parent has to fight some way or has to get money some way to pay out of pocket. This is not right for these families. And here, I like the conclusion that I wrote up. I really got carried away yesterday when I was writing this, so I'm going to read this and my time will be up. With all the problems caused by the CMOs, families and children with special needs are suffering. If we leave here today with nothing else, let's at least have that understanding. In addition, the state, through the early intervention program, must pay therapists for the treatment documented in the IFSP for all children under the age of 3 years. This is a legal document, the Infant Family Service Plan. So if a physical therapist treating a 0 to 3-year-old doesn't get paid from Medicaid, doesn't get paid from a CMO, then they have to do more and more and more paperwork, and they still get paid by early intervention. But by that time, you're so worn out, and the children's been on hold for so long that they've regressed by the time you're out there to treat them. This state, Georgia, has so very much to offer children with special needs because of its excellent medical professionals and educators. Rather than being a state where these families are doomed to suffer unrighteously, I want to reside in a state that is known for its expert care and concern for the special children that live in Georgia. I believe this would be a wonderful legacy for the state of Georgia. Thank you.
My name is Paul Davis, and I'm co-owner of Pediatric Physical Therapy in Augusta, Georgia, and I take care of the billing part. And my main concern is that the state of Georgia is on the verge, and it's not just on the verge, it is already happening, a complete collapse in service delivery systems for children 0 to 3. Because, number one, somebody said we haven't gotten a raise in 5 years. Since 2002, our fee scale has been cut $26 per visit. That's a fourth. Our therapists, we have to pay them a fourth of what a fourth less than what they earned in 2002. And back then, we had 4 full-time therapists and 3 part-time. 4 part-time, 5 part-time. Now we have 1 full-time therapist and 3 part-time. We worked and developed a program with the Medical College of Georgia, and we had a lead physical therapist that would help to train new graduates. We were able to add 1 last year and 1 this year. And you know how many survived the fiasco of this past year? None of them. They both resigned because they couldn't deal with all of the paperwork. And I am angry. In 2002 and 2001, we were paying $8,000 to $10,000 a year in income tax. You know how much we paid in income tax last year? $0. We got money back because we got a tax credit from buying a heat pump. We had to borrow $15,000 just to pay our therapist. And if it had not been for early intervention, we would have been out of business. And the crazy thing about this is, do you know how much all of this, the Medicaid, let me talk to the Department of Community Health people. Do you know, I don't know if anybody's thought about this, but you know how much the prior approval system for Medicare or Medicaid and the CMOs can save the state of Georgia for children 0 to 3? Nothing. Absolutely nothing. Why? Because before anything happens, early intervention goes out and finds the children that are special needs. They go through a process of working with a doctor, the primary treating physician, and any medical specialist they need, with registered physical and occupational and speech therapists, whichever ones are needed in the case. And together with the family and the service coordinator, they develop an individualized family service plan, infant family service plan, required by law, by federal law. And once that contract is signed, which specifies the amount of therapy, even the CPT codes that are going to be used, the frequency of therapy, the state of Georgia is legally bound to pay for that therapy through the early intervention program, which is paid for by the state. So all of this work that they're making us go through, and with Medicaid right now, it is taking us 3 to 5 times effort just to get a prior approval. And we have a PhD on our staff who is a full professor at the Medical College of Georgia Physical Therapy Department. My wife has a master's degree from Emory University, and if after a year it takes us 5 times to get a prior approval, something's wrong with the system, something's broken. And it means nothing. It just means that we have to go through that hoop, play this game, and then we bill early intervention. The state still pays for it. Is that smart? And my company is about to go under. And early intervention service coordinators can't get paid, and they're beginning to quit. We just lost a physical therapist that took care of the whole Thompson and McDuffie County area. And she couldn't take it. She couldn't make enough money to make ends meet. And she had to quit. How do I know that? Because we had to revamp one of our therapists. And she's taking her time to go up there to cover part of that caseload. And the children they're supposed to be seeing 2 times a week can only be seen once a week because we're trying to get as many of them as we can. And then you have people like WellCare saying, oh, yeah, we're going to approve it. We'll let you see them 2 times a week. Medicaid, we don't even have to have a prior approval to see a child 2 times a week. These children are so desperately involved, it is criminal. It is insane for any of them to say that. So I call these so-called, what was the word that you guys used, the ones that they're supposed to manage them? Most of the time I can't get through to anybody, and they'll call me back, but they don't. And when I have, they say, this is policy. We can't approve it for any more than that. You can appeal it if you want to, as if I had time to do that. And I say, let me speak to a supervisor, and they're never available. Never available. They said they'll call back. You know how many calls I've gotten back? None. It looked and it sounded really good up there on the screen, but when it gets down to us, it is not working. And if you guys in the legislature, when we worked on House Bill 549, it was critical. We are beyond critical now. If you don't do something, if you wait till next year, it's too late. You may not have an early intervention program because it's been overloaded. It was never intended to pay for all this stuff. The service coordinators can't last that long without getting paid. Physical and occupational and speech therapists cannot last that long because we can't afford not to get paid. Somebody do something. I didn't stay with the script, but there's a lot of documentation to document why we really are. It's not just us that are about to go out of business, but most of the therapy groups, I don't know what they're like in Atlanta, but they're not big. We're small. And we cannot continue to endure these losses. And what are you going to do if all of us go out of business? Even if you can put together some miraculous cure after the fact, how long will it take you to rebuild the whole infrastructure so that children can be taken care of? What are you going to do when nobody is available to take care of these children? You guys could have the distinct privilege of being a part of the state legislature and governor who failed all of the children of this state. And if we don't reach them in the first 3 years of their life, they will bear that burden. You use that window of opportunity for their primary improvement in life. It will affect them for the rest of their lives. How many generations of these children will suffer if you don't do something?
Beverly Rossberry. Beverly Rossberry. Polly Boyd. Polly Boyd. Please.
Hello. I'm speaking on behalf of Polly Boyd. She was here earlier this morning. I'm the family advocate with the Community Partnership for Protecting Children. This is a new experience for me. I guess I could kind of change the tone, though, because there is some good. Working with the mayor group in East Point, they are a partner that I can always count on to be in our community. We are getting ready to go through gentrification. A lot of the families weren't even aware about the different changes. Georgia families have also done a good job at being at the DFACS offices and in the doctor's offices. But a mayor group, their name speaks for itself. They really do care. Any event in East Point, College Park, they're there. There's never a time I can go to them, and they cannot be there. I'm also a parent. My children are AmeriGroup Group members. Before AmeriGroup Group came into the community, I was with WellCare. I had a tremendous amount of problems with getting my son's eczema creams. He has severe eczema. But with getting AmeriGroup Group, they make the community aware of what those incentives are that they do provide with being a member. Being a member of AmeriGroup Group has helped me tremendously. I'm a parent that does not have insurance. I have to pay every time I go to see the doctor. By them having the incentive of after-school care helps me, because that's more money out of my pocket when I have to go to the doctor and I get sick. With AmeriGroup Group being in the community, it's very supportive to a lot of the families. I can truly say AmeriGroup Group is one that I will always support, and that's why I'm here today. And it just seems, with listening to everything that I've heard today, it should be some shared decision-making. Some family involvement would help in a lot of the decision-making if they were allowed to be able to be aware when they could come to these types of meetings. AmeriGroup Group made it aware to me that this was one that I needed to come out and actually share my testimony with how they help us. I'm nervous, but I can only speak from my heart and truly say AmeriGroup Group is one that really does care. I have never seen one Medicaid group from the others that actually came into the community. The marketing vice president, Mr. Kevin Hughes, I got to actually shake his hand. They're there. They're at the doctor's offices. They're in the schools. They actually know what a lot of the residents are dealing with. Anytime there's an event and we don't know what resources are in the community, I can always go to Naima, who is in the marketing department, and ask her. And she can give me a resource that I did not even know was available. I'm not for sure about the other, I don't know what you call them, PCP, HMO, CMOs, but AmeriGroup is one that I can always go to, and they're very informative. They make all of the members aware of what is out there for them to help them. And that's all I have to say. Thank you.
Dr. Marty Michaels.
Thank you, Chairman Chanel and Chairman Goggins, and thank you, legislators, for this opportunity to speak. Hello to my friends from DCH and the CMOs. My name is Dr. Marty Michaels. I'm president of the Georgia chapter of the American Academy of Pediatrics. We are an organization of 1,800 pediatrician members from across the state. I'm a volunteer in that position. I earn my living as a primary care pediatrician, serving mostly Medicaid and peach care patients. Very briefly, I'm going to be speaking from the first two copies of your handout. I'll be speaking from the blue page and the green page. The last two pages are just reference material for your later review. Our organization with our pediatricians provide care to a large number of the children that are served by the CMOs. There's approximately 800,000 children enrolled in Georgia Healthy Families, and pediatricians who are members of our organization serve a large number of those children. We are comprised of pediatric primary care physicians and subspecialists as well. And our intention as an organization is to be a proactive resource working together with DCH and with the CMOs and with the legislature to ensure that the kids get the care that they need. With that said, I'd like to look for a minute at the green page, which has a visual diagrammatic. And this is, I tried to ask myself, if I was a legislator, what would I want to hear in 5 minutes from the president of the Academy of Pediatrics in Georgia? Well, I'd want to know the big picture, first of all. This is what I see as the big picture. You know, if I was a legislator, at the top of what I'd want is value. I would not want to compromise the health care outcomes of any child in the state in these programs. So I'd want an excellent outcome, but I'd want it for the darned lowest amount of dollars I could get it for. And that's what you call value, is when you get a good outcome for the least dollars. Right underneath value, you have to measure your outcomes or you have no idea what the value is. I mean, I can tell you we spent $70 million less or $250 million less or $500 million less, but if I don't know how many kids I served and what their outcomes were, I know nothing of value. Going down a little further, to have quality outcomes, you got to have access to care. So you got to have primary care doctors and you got to have subspecialists. And those little squiggles are not because you need a new pair of glasses. Those are the cracks in the parts of the pyramid as I see them now. So there are cracks in the access to care. Down below that, what supports access to care? Well, two things. Logistics, like prior authorizations, prior approvals, claims filing, claims payment, credentialing, things like reasonable payment levels for providers. There's no Medicaid provider that expects outstanding payment, trust me on that, but reasonable payment is expected, and there's cracks in those areas. At the very base is appropriate funding from the federal government and the state government. I didn't put any cracks there because I think maybe for $6.5 billion this can be done. But there's another crack at the foundation, which is enrollment. We've got 100 to 150,000 children in Georgia today that are eligible for Medicaid. They are U.S. citizens. They do meet income requirements, and they're eligible for either Medicaid or peach care, yet they are unenrolled. And that's about a half of the 300,000 uninsured kids in Georgia. So if you want to do something positive about the base of the pyramid, fix the enrollment crisis that we have. Get the eligible kids enrolled as soon as possible. Going back to the blue page, the overview, number 1, 2, 3, Roman numerals. We've talked about the pyramid concept. Number 2, the transition. How was the transition? It was very rocky and turbulent. That's really all I'm going to say about it, because I could talk about that for 3 hours. Number 3, how is it going now in August of 2007? Well, it's better than the early rollout. However, there's very critical problems. If they're not addressed, there will be health consequences for children. It's very important to realize that any problems that I mention in the next part of my talk are linked not just to the CMOs, but it's inextricably linked to DCH policies and how that interacts with the CMOs, because the CMOs by and of themselves cannot fix the problems that exist. That said, there's 5 critical parameters that I use to assess the status of the CMO transition. Those 5 parameters are value, which is the top of the pyramid, quality outcomes, access to care, logistics, and payment to physicians. Going in order, number 1, value. Value is excellent outcomes for kids per dollar spent per member per month. Okay, so if you've got all the kids enrolled, that's fine. But if you don't have the kids enrolled, you can't really just say, well, I saved $78 million, therefore it's a good thing. You got to compare apples to apples. You got to know how many kids were enrolled when you spent $78 million more, and how many were enrolled for how many months now. How many member months was it? There's serious gaps in enrollment. It makes it impossible to measure value. Quality outcomes, there really is not substantial data that I have seen at this point. So we need data on quality outcomes. I've listed details on what that involves. Access to care, you've heard there's problems with OT, PT, speech, ophthalmology, orthopedics, mental health, vision, dental, and now primary care. You may not have heard that, but we have done an access survey that shows there's problems with access to primary care. When you have a list of providers that says geographic region, this is the number of providers you have, that's not true access. To measure access, you have to measure, can those people really get to those providers on the list? When they call, do they get an appointment? That's the measure. That hasn't been done in a thorough way to date. Number 4, logistics. There's need for significant improvement. Dr. Catherine Cheek is going to speak more to that later. Payment to physicians. Physicians are paid at Medicaid base rates that are 6% below 2002, and we're in 2007. So in 5 years, there's been about 15% inflation. Medicaid base rates are 6% lower than 2002. So that's a problem. If you were to ask me, and this is my close, 5 urgent interventions that this committee could ask for to improve the situation, this is what I would list. Number 1, establish ongoing legislative oversight, such as this committee is doing, but an ongoing oversight to oversee DCH and the CMOs and that interaction. Number 2, streamline logistics. That's a CMO and DCH issue. The primary care assignment problem is the most urgent logistical problem, and it needs to be fixed immediately, and it can be fixed. Number 3, enroll all eligible children as soon as possible. Enroll the 150,000 kids that are eligible for Medicaid or Peach Care as soon as possible. Number 4, measure access to care and outcomes in a valid way. There's more details about that in page 3 and 4. And number 5, ensure a reasonable payment floor for physicians for both the CMO and the fee-for-service programs. The recommendation in the budget proposal from DCH to the governor's office of 88.5% of 2007 RBRVS is an excellent move in the right direction. Thank you.
Thank you. Ladies and gentlemen, the chair once again ask if you would work with us best you can. We are not quite 40% through yet. And again, there are a lot of people in this room who come a long distance. So do your absolute best, please, to respect other people's time and stick to the 5 minutes if you will, please. Thank you. Dr. Catherine Cheek.
I'm Catherine Cheek. I'm a pediatrician that has worked in the state of Georgia for 25 years. I'm here representing the Georgia Chapter American Academy of Pediatrics Medicaid Committee. I'm the chairperson for that committee. First, I want to remind you that 60% of Georgia's children are eligible for Medicaid when they're born in this state. So 60% of the births are Medicaid babies. 80% of the patients that were transitioned were children. And 1/2 of all pediatric practices in Georgia have at least 45% Medicaid population in their offices every day. We were asked to keep an old system and put a new 2 to 3 systems in place. This is a challenge, and you've heard the challenges. The good was that we were able to have conference calls with DCH. We've made some slow, steady progress. We have identified CMO directors that we can contact with problems, and we have had some resolution of some problems. And most providers are getting some payments. This was not the case early on, which you have heard. Many providers went up to 2 months with absolutely zero payments to their office. I have listed for you, and in the back of your handout is a spreadsheet documenting the problems that the Georgia chapter has received since August of '06. Remember, many of our members were actually transitioned in June, so they've been into the system well over a year now. These are the number of complaints. We try to divide them up as what the complaint's about. In your handout, I have listed examples of each one of these complaints, and I think you'll see that they're very similar to the things that you've already heard here. I'm not going to go over all of them. We do think this is probably, since we did receive 1,469 complaints, and we have all of those at the office. Anybody that wants to come read them, feel free. You may feel some pain as you go through them. People don't sit down and fill out a hassle form at the end of their busy day with all the struggles that we have in medicine today unless you're really tired and sick of the problem. So we do feel that this is the tip of the iceberg. I'm going to highlight just a few of those. Some reductions and denials and payments that seem almost silly to us. When these national programs went live, several of the CMOs did not load immunization codes, the payments for those. These are national immunizations, national companies. You know, you ask the providers to give an immunization. We all know that for a child to enter school here in Georgia, they have to have immunizations, and then that's not loaded in their system. That seems like a fatal flaw to me. Another example of things that seem ridiculous. Even today in my office, if I have a child with meningitis or I'm concerned they have meningitis, I'm supposed to stop and call and get a prior approval for a lumbar puncture? No. We still have very significant problems referring our patients to subspecialists within these systems. I think Representative Stevens has already alluded to the fact that in our offices, on a daily basis, we have to verify eligibility. Our offices go online. We verify that a patient is eligible. We provide those services to that patient. We bill the CMO. The CMO pays us because they, too, think that patient was eligible based on their standing where it is. And 3 to 4 months later, they recoup that payment from us and tell us to refile with another company. This is not fair to physicians. It's not making very happy providers. We had one drug formulary that over the Memorial Day holiday decided with no explanation to physicians or no notification to physicians and pharmacies that suddenly they would no longer cover EpiPens for our diabetic patients. They said that the children should take syringes to school. And a utilization management coordinator says that each doctor's office should contact each school system and ask them to write a letter stating that it was illegal for a child to have syringes at school. We want to be a part of the solution, and I've listed some of the things that we think have got to happen to make a difference. We have to communicate, which we are doing. It's got to be improved. And providers must be present at the table at all levels to make a difference. All parties, providers, and these CMOs must embrace technology. And we have web portals that are not at the current standard that they were before we started the system. This is a system that has gone backwards instead of forward. Once we identify problems, we got to find solutions, put the timelines in place. This miseligibility, misassignments is colossal. The fact that a baby can be born in Georgia, and we really, in 48 hours, should be able to have a Medicaid number and a CMO and a primary care doctor. This is Georgia, 2007. 48 hours is reasonable enough to get some kind of number that's usable and the provider can use and the patient can use. Come on. Anyway, we are more than willing to work with you. Please help us get our providers enrolled. It currently takes 90 to 120 days. There's no reason for this. If I've got a new provider wanting to go to work, 30 days is certainly reasonable to check my credentials. Thank you very much for your time.
Thank you. What we're going to start doing is calling up the next person and also the person that follows that person. So I'll call out two names. The second name, y'all come on down here and be ready to go. The next presenter is Dr. Susan McWhorter, and next up after that is Jeff Hubbard.
Thank you. My name is Susan McWhorter. I'm a pediatrician in private practice in Columbus, Georgia. Our practice has 10 providers, and we've always accepted Medicaid patients into our practice. We currently see about 30% of our patients as Medicaid patients. I wanted to share with you some of the problems that we've encountered along the way during this transition to the CMOs. First thing that has been mentioned, verifying eligibility. One of the CMOs says it will take up to 30 days to verify a newborn's eligibility, which means we see that patient in the hospital for several visits and at least 2 office visits before we're even sure that that patient is covered. Therefore, we're not able to verify the eligibility and even file the claims to get payment for up to 30 days. Other problems we've talked about, subspecialist coverage, particularly orthopedics, was a very big problem, particularly in the first 6 months of transition. We had one patient who had broken her leg, was diagnosed in the emergency room, came to us for follow-up, and we had very much difficulty getting that child seen for follow-up. We called orthopedists throughout our city in Columbus. We called ones in LaGrange and Macon and the Atlanta area, and it was very frustrating for the mother whose child needed treatment, as well as for us because of the time that our office staff had to spend trying to find a place for this child to follow up. Very frustrating. Dr. Bug mentioned about Synagis administration. Synagis is a medication given monthly through the winter season to premature babies to prevent infection with a virus called RSV. We had one mom who had triplets. One was assigned to Medicaid, and for some reason the other 2 were assigned to Peach State. The child under Medicaid was approved for the medication, but the 2 on Peach State were not. It doesn't make sense that the guidelines for approval are different between the different CMOs. It should be the same. There's some universal recommendations on which children should receive this medication. But the mom was very frustrated because one child got the medicine, but the other 2 did not. Prior authorizations has also been mentioned. What we've seen a large impact on our practice, particularly with medication formularies. The CMOs put out their formularies and then they change often enough that we can't keep up with it. And our nurses and the physicians spend a great deal of time getting callbacks from the pharmacies trying to figure out what we can treat these patients with. We've had patients with known penicillin allergies, and we're told by the CMOs that we have to use a penicillin drug for this diagnosis, and we're not allowed to use something else. That doesn't make sense. It's been very frustrating. We had also one case, a child who had seizures, and we could not get the CMO to approve Diastat, which is a medication that the mother can deliver at home to stop the seizures. Because we couldn't get the medication approved, the mother ended up taking the child to the emergency room for several visits, which ends up being very costly and very frustrating. Also, credentialing new providers, it does take at least 3 to 4 months to get credentialed as a new provider, and that delays good care for patients as well. As I said, we've always taken Medicaid patients, and it's been a large burden to us administratively as well as financially, and we are discussing as a group, should we continue to take patients who belong to these CMOs? And that's something we've never talked about before. It's been very frustrating for us, and we hope that these things can be remedied. Thank you.
Chairman Goggins has a question.
Let me ask you a question, please.
Yes.
Please explain the penicillin allergy that you talked about.
Well, particularly with the diagnosis of otitis media, the CMOs recommend that first-line treatment is amoxicillin, which is typically what we use, which is a penicillin drug. If the patient is allergic, we usually go to what's called a cephalosporin category. But the patients, the ones that are really indicated for otitis media are slightly more expensive, and therefore they don't cover those. And what they have to do, a lot of times the pharmacists say they have to put through a penicillin drug through the computer system before they can get the other one approved. So logistically, it's the way to try to get around the system to get the drug that you want to use. And then if we can get a cephalosporin approved, a lot of times they only pay for Keflex, which is not even indicated for ear infections. It's indicated for other diagnoses, but not necessarily for ear infections. So the patients that are going to the pharmacy, and it's just the time consuming to get callbacks to try to find a way to get around the system to get the medication that you think is appropriate.
Thank you.
Jeff Hubbard, and up after Mr. Hubbard is Julie Wyndham.
Thank you, Mr. Chairman and committee members. I'm Jeff Hubbard, president of the Georgia Association of Educators and an elementary school assistant principal in Clayton County. Investing in the health and the well-being of Georgia's children is of the utmost importance to our long-term physical and dental health at the individual level, the family, the school, and the community level. For the 1.6 million children in Georgia's public schools, failure to take care of our youngest and most vulnerable citizens and providing them the services they need to thrive and succeed will further divide our state into the haves and have-nots. As an educator of 22 years in Georgia's public schools, I've seen the values of such programs as the dental vans and healthcare providers that give of themselves to come to Georgia's public schools to work with those who need our services the most. This issue is more than an economic issue. It is an education issue. It is an empowerment issue for the future generations of Georgia. Statistics clearly show that students whose needs are not being met have greater absenteeism rate and lower academic achievement. We are hopeful that the problems of funding and of reimbursement that the CMOs are having will be an asset instead of a problem for Georgia's children and taxpayers, and not an additional burden. We can either pay now to protect our children and our students, or we can pay later. I'd like to yield the remainder of my time to Margaret Price from Page.
Thanks for giving me the opportunity to speak. I just want to say briefly that Page is supportive of the program. We agree with what Jeff Hubbard from GAE just mentioned. We certainly want our kids to be healthy and happy, strong in schools so that they can pay attention, so that they can learn, so that they have good behavior, which is easier for our teachers to deal with, certainly. And I'd like to yield the remainder of my time to Jane Wilson, a retired principal from Bremen.
You're talking about something today that is very passionate to me. I've had a burden for the children, particularly the children of the state of Georgia, for many years. I was in education for 44 years, 15 years of those. I was the principal of an elementary school. Children exist at the mercy of their caregivers, whether it be the parents, their relatives, or us, the citizens of this state. The only access they have to meet their needs and the level of the responsibility that is felt by their caregivers. Our responsibility is to seek solutions for the problems that children of today face. They do not choose their living conditions. They are powerless to change their immediate circumstances. And for this reason, education and governmental intervention is their best chance of having a future, of being good citizens and good providers for themselves and for their future families. One of the things that I would like to address today has to do with the dental issues. How many of you have had a toothache? How many of you have had an abscess tooth? Could you take the CRCT? Could you smile and play? Could you sleep at night? The only answer for children who have difficulties is to have access to a dentist who can give them proper care. I have seen clean children dressed to the best that their parents can do. And as you walk out to the car to put them in the car to leave school, you see just a little bit of the truth of the deplorable situation and poverty that they are in. The poverty that some children are in is our worst nightmare, and we must address the needs of children. To be able to smile, to be able to have all of your teeth by the time that you're in high school, to be able to grow up with great self-confidence and know that you have the power that is available to children of our nation. And I think it is deplorable for us not to provide for them at the level of care that we can. And prevention is the far best thing that we can do. While I was principal of the school, we had several times the vans came out to the school. Those of you that are not familiar with this, they came, dentist pulled up into the back parking lot, and those students that needed to be seen were able to be seen and referred to for health care. And I just challenge you as our lawmakers to really provide for the children of our state, because they deserve it. Thank you.
Thank you very much. Anybody that taught school for 44 years, you got a special place waiting on you somewhere. Julie Wyndham is up next, and following her will be Jim Lowry.
Good afternoon, Mr. Chairman and members of the committee. My name is Julie Wyndham with the Georgia Alliance of Community Hospitals. We're an organization representing over 80 not-for-profit hospitals throughout the state of Georgia. I want to thank you for the opportunity to speak to your committee today. I will be as brief as my southern accent will allow me to be. I'll provide you a general overview of the major issues hospitals are facing today, divided into three categories: patient care, administrative issues, and finally financial issues. First of all, with regards to patient care, we're seeing a severe shortage of physicians and specialists who are treating Medicaid managed care members in this state. These shortages are most severe in rural areas, especially in the areas of practice of orthopedics, neurologists, and pediatric specialists. The way that patients are dealing with this shortage is, one, they're traveling far from their home to see a physician or a specialist, or two, they're simply not getting the treatment and they're showing up in our emergency rooms for an illness that could have easily been handled in a doctor's office. The premise of Medicaid managed care is to manage utilization through care management. However, we are seeing very little, if any, decrease in emergency department utilization, and we are seeing a very minimal level of member education in our facilities. And finally, with regards to patient care, pre-certification delays often result in patients being sicker longer than is necessary. With regards to administrative issues, we're seeing a number of issues with IT interfacing because of the different systems that each CMO requires us to implement and to learn. And once we file claims electronically, very often claims that are denied revert into a paper trail, which results in increased administrative costs and further delays in payments. And finally, with regards to IT, I want to reiterate the need to put a system in place so that hospitals can obtain the necessary data that they need to continue to pull down the over $400 million in DISH funds that are very vital to a number of our facilities. We're also seeing problems with interaction with CMO personnel. Many of our staff report calling CMOs and getting inadequately trained representatives manning the phones. Often these representatives refer to policies that are in direct conflict with our individual contracts with that CMO. We're also seeing long wait times on calls for pre-certification, many times between 45 minutes and an hour, just to simply get pre-certification. We also find a problem with local CMO representatives having very little decision-making power, which means that most decisions are made at the corporate level, and therefore unique situations and factors in many areas of the state are not taken into account. With regard to denials, you've heard about the problems with the prudent layperson standard. For emergency visits, each CMO has a different standard, and we would simply ask that our facilities be informed and receive some clarification as to what each CMO sees as emergent, so that we will know once that individual walks into our emergency department whether that is an emergent situation or not. We're also seeing claims being denied for issues that are out of the provider's control. For example, very often a patient changes the CMO during their hospital stay, as is common with newborns, having a different CMO from their mother. We're also seeing some denials because of the timeliness of submission. Some CMOs are looking at the admission date rather than the discharge date, and when you have a long stay in the hospital, that results in a denial for the unreasonable timeliness of that submission of that claim. As was mentioned earlier, a large number of these denials are being overturned eventually. However, we bear the brunt of that administrative cost to go after that payment. Finally, on administrative issues, the appeals, currently they're made directly to the CMOs with very little recourse outside that CMO. We would just simply ask that DCH consider a process whereby the provider can appeal to the department, not on every denial, but on a limited basis to make sure that we're not unnecessarily having to fight for those payments. And finally, with financial issues, overall providers' reimbursement is less under Medicaid managed care than traditional Medicaid, but however, the program utilization is fairly stagnant. According to a survey by VHA Georgia, the overall number of Medicaid visits to hospitals has dropped by 2.8%. That's outpatient, inpatient, and ER visits, while the total payments fell by over 12% after the implementation of managed care. In addition to these decreased reimbursements, a number of facilities have had to add staff for the sole purpose of handling the increased workload. One facility in North Georgia reports spending over $250,000 last year on additional staff solely to deal with administration of the managed care program. Delayed payments result in cash flow issues for many facilities. Another hospital reports an average of over 30 days for claim disposition with the two CMOs in their area versus an average of 18 days for traditional Medicaid under the fee-for-service system. As you've already heard, emergency room claims are being paid at the triage rate of $50. A South Georgia facility reports that 82% of its claims in the ER are being paid at the triage rate by one of the CMOs it deals with. Under fee-for-service, this facility only saw 15% of its claims denied on average. And finally, I'd like you to keep in mind the significant decrease in the UPL funds that we're facing. We possibly have left $70 to $100 million on the table that we could have drawn down from the federal government that would go to our hospitals to help supplement some of this care. And we'd just like you to keep that in mind as you're looking at some of the issues that we're facing. Mr. Chairman, thank you very much.
Thank you very much. Jim Lowry, and after him, Dr. David Anthony.
Thank you, Chairman and committee members. I'm here for Mr. Lowry. He was not able to attend today. My name is Dina Zinker, and I'm the Director of Emergency Services at Colquitt Regional in Moultrie, Georgia. We're a small rural hospital, and in the emergency room particularly, we see about 600 Medicaid patients a month. While that number has not decreased since the care management organizations have consumed Medicaid, what we have noticed is a huge decrease in our reimbursement, $25 to $30 per visit, and also we're having to work a lot harder to get that lesser reimbursement. With 28% of our volume being Medicaid, you see the challenges that we're under to continue to provide high-quality care. The care management, we're really not seeing any effects of care management from the care management organizations. What we are seeing is much difficulty in claims processing, and that seems to be where the focus is, on making it difficult. I could give you so many examples, like you've already heard this morning, of children that we've provided care for who return to the emergency room numerous times to try to allow us to help them find a specialist, and they're just not there. We have an orthopedic surgeon in our area who wants to be a pin in the map, but it's going to take him 90 days after a 54-day waiting period to get a Medicaid number to get a WellCare number. So, he could be another pin on that map and actually, be part of the solution. But, 6 months, it's really intolerable for us to have to wait that long. In thinking about things that it could be fixed, right now we know. I heard Ms. Riggers admit that, rural areas are a challenge for specialists right now. There should be something built into the system to allow specialists that will provide care to a physician, to a patient who needs specialist coverage and actually receive reimbursement. I personally made a phone call to one of our orthopedic surgeons because I have a 7-year-old in the ER who should have already had surgery on a broken arm, and he said, I won't get paid for this, and I'm still liable for the care that I perform, and I have follow-up care. And I said, yes, doctor, I do, but I need someone to see this patient. Those are the conversations that we're having, and then when you ask them why won't you be a part of WellCare? Because it's too much paperwork, it's too much time on the phone, and I'm not going to get paid. Those are the problems that we're facing in Moultrie. Thank you for your time, and I know that you guys will work hard to find the solution.
Thank you. Dr. David Anthony, followed by Daniel Worley. Dr. Anthony. Daniel Worley. And next up after him will be Donna Davison.
My name is Daniel Worley. I'm practice administrator for Riverdale Anesthesia, and I'm also president of Georgia Anesthesia Administrators, an educational organization for the billing practices for the group. I also have with me Jamie Chesson, who is with New London Anesthesia, and she will explain the details. Just to be brief, in June of 2006, we tried to sit down with the individual CMOs to come up with the specifics for the contracting because we knew that the problems that we had with ACS when they came on board, we were trying to prevent those. The individual CMOs did not give us the individual specifics of the contract. Anesthesia is a little bit different billing process than a lot of the other carriers or a lot of other specialties in that we use space and time and so forth. Our practice in the last 10 years has grown dramatically in Clayton County. Our patient population has increased probably, 28%, but our Medicaid population has increased 147%. On our managed care contracts, our commercial side, we're paid approximately 80% of our billed amount, while Medicaid pays us at 19.99%, which puts an emphasis on us to get those claims in, get them paid clearly the first time so we do not have the additional expenses of rejudicating those claims. From the onset, Georgia Anesthesia Administrators sat down and tried to get things straightened out with Medicaid, or with the CMOs. We attempted in November to have them, and we had them come to our educational meeting November 9th. Each of them came in, they explained their positions. The membership had an opportunity to speak to the representatives, were middle management and senior management with the CMOs. Some of the problems were underpayments and overpayments. One of these CMOs stated that on one specific code, they knew that they were underpaid, that they would not go back and recoup that money from us until they had it straightened in their system. Another one came in and said that if any other practice had financial problems, severe financial problems due to the crisis, that they would front them any money. So the membership went away from that meeting feeling that the problems were addressed and that they would be cleared up by the end of the calendar year. Come April of this year, the problems still existed. So we went back to the CMOs as a group. We went back in and had them come in and present a meeting at one of our group members' offices, and then we went back to their individual offices of the CMOs to address those issues. One of the issues was that the payments, we were under the impression, because we were not given the specifics and there was no website that we can go to or any documentation that will support how they will pay anesthesia, we were under the impression that they would pay the same way that ACS paid. They came in and they said, no, we do not pay according to that. That guideline is out there, and I believe Ms. Driggers had said that the guideline is out there that they can pay, and most of them will pay according to that guideline, but they have the option of going out and paying outside. The problems that we had range from no formal training of CMO claim personnel for medical specialty as to the billing requirements, providers not being recognized by the system, providers' names incorrectly entered into the various computer systems, and providers not being recognized for one or more specialties, no formalized billing manual presented or available, and no published fee schedule. And we received payments that were incorrect when compared to the ACS system. Recognizing that it takes two to tango, the Georgia Anesthesia Administrator sat down with them, tried to rectify the problems, and we still have not gotten anywhere. Most recently, I've gone back to in a particular problem where we had providers that have not been paid. I went back and said to one of the CMOs, I want to meet with you at the State Insurance Commissioner's office. They have come back and said, okay, we got this problem straightened out. It'll take 45 to 60 days to see if that problem is correct. Well, that's the problem that we run into all the time, in that the individual staff try to work through the problems, but we have to wait for a period of time, and then we find out that they're not corrected. I'm going to turn the rest of my time over to Ms. Chesson. Thank you.
I'm going to try to make a couple of points very quickly. My name is Jamie Chesson. I'm representing New London Anesthesia. I'm also a GAAA member. I want to hit some of the points about each specific CMO so we can address their specific issues because they are inconsistent from one another. It's very important for me to note once again that we're not making money off of Medicaid patients. We're certainly not trying to make money off the CMOs. It's how much can we afford to lose and how much can we do without getting paid. Many providers are closing their doors, and this is becoming a very serious problem. The one thing I can say about WellCare specifically is they are inconsistent. They pay on lots of claims, but they do not pay correctly. There is not a consistency in payment structure from claim to claim, from procedure to procedure, and we have claims that we have been outstanding for quite some time. For the first 6 months after the inception in June of this program, they would not pay for tonsil and adenoid surgeries for children. This is a very common procedure, and we are still, a year later, trying to fix those same claims. Let's see. Another point is WellCare did not credential their anesthesia providers as pain management specialists, even though the credentialing information was set up. They have dual specialties. They are also, as of yesterday, they informed us that they are requiring a 3-year fellowship for anesthesia professionals to be certified as pain management specialists. That is not a requirement that anyone else in the state of Georgia has. These are providers that have been approved by ACS, by DCH, by commercial payers, and have privileges and facilities to do these services, but they are no longer getting paid. Peach State has shown inconsistency paying for obstetrical anesthesia. They paid at 45% of billed charges due to a lack of written policy at the beginning. They are now coming back and going all the way back to June of 2006 to take those payments back from providers, and they're repaying incorrectly at rates below that approved by Medicaid. The appealing of all of these procedures and the constant work to get these claims paid correctly is costing our providers more than what we're even getting paid. Let's see. Also, they have outlined certain codes as being included in surgical reimbursement due to being paid at certain locations. No logic to these codes. I don't know why they're doing that. They have also established their own timely filing period, which is far shorter than that of Georgia Medicaid. And they are not paying for anesthesia for dental procedures for children that require it, back again to dental, because they will not accept the concurrency modifiers required by DCH and by Georgia Medicaid. Lastly, let me hit on AmeriGroup very quickly. I do not know what AmeriGroup was allowed to do, but AmeriGroup has created unreasonable delays that are detrimental to providers in enrolling these providers. Hospital-based providers, which anesthesia are, were allotted a 10% penalty by AmeriGroup on every payment until they became contracted. That's counterintuitive. AmeriGroup has now got an incentive to not enroll hospital-based providers. Our contract has personally been on file, signed for, at AmeriGroup since September of 2006. It was put in our provider representative's hand again in April of 2007. End of August, we're still not loaded. And we're still getting a 10% penalty on every patient we see. AmeriGroup, although they seem to reach out to the public and are able to attend outreach facilities, they are not paying claims. We have claims all the way back from June of 2006 that are still not paid correctly according to Medicaid guidelines or according to any written guideline that we can find anywhere. We really need help. We've done everything we can. We've spoken to every representative from every CMO, every director from every CMO, contacted DCH. We are at the end of our ropes, and it is costing us quite a bit. Oh, and the solution is that, I think, that the CMOs should be required to adhere to the guidelines outlined by Georgia Medicaid and DCH for payment.
Good afternoon, Chairman and members of the committee. My name is Donna Davidson.
Yes, ma'am. Ms. Davis, hold on one second.
I'm sorry?
Yeah, you are, in fact, Donna Davidson. Karen Coulter will be up following her. She will come on down. Go ahead, Ms. Davidson.
Okay. My name is Donna Davidson. I'm the president of Easter Seals North Georgia, and I'm here representing Easter Seals, the Georgia Speech and Hearing Association, and the Tri-Alliance of Physical, Occupational, and Speech Therapists. I'm sure you all are going to have a major headache when you leave today. It sort of feels like a record that keeps on repeating itself with all that you're hearing. Prior to the CMOs going into effect, members of the Tri-Alliance met with DCH continually to sort of try to hedge off some of the problems that we anticipated occurring as we entered into the CMOs. After that, we have worked continuously with the CMOs for the past year in trying to iron out some of these issues. And because we were unable to rectify these issues, we worked with Representative Burkhalter on House Bill 549, which gratefully was passed by both the House and Senate, but vetoed by the governor in the later hours of the budget session. We first want to thank you all for your support on House Bill 549, but we're here today to tell you that these issues are still present in all of their forms. What's been real interesting today is I sit in the audience as a provider of therapy services, but you know, whether you're listening to the physicians or the dentists or hospital administrators or specialists, the issues are really all of the same. Everything that you're hearing today is the same. You've got physicians that are coming here from far away that are taking days off from providing care to patients to come and talk about these critical issues. And believe me, they wouldn't be here if they weren't critical issues. I'm here today to talk about what I believe would be some very simple solutions that could help make the CMO transition easier. Number one, we need improved accountability with both the CMOs and DCH, just simple things like the form of contact people who have both the authority and the knowledge to resolve issues between families and providers. If you call and speak to 3 different people at the CMOs, you get 3 different answers, and it's very frustrating. Number 2, being responsive to problems. We have requested simple things like prior approvals and denials in writing that we can't seem to get from the CMOs. Third, and this is kind of like a would like to be reimbursed in a timely manner for services that we provide. You have lots and lots of providers here that are very small practices. They cannot deal with the cash flow issues that are being created by not receiving payments. Individual therapists who are owed $10,000, $15,000, $20,000, they don't have the cash flow to support that. Number 4, provider credentialing. You may hear that there's a lot of accessibility to providers, but if you took the study on how many providers who were enrolled are actually treating patients through the CMOs, I think you're going to find a very different number. One of the things that occurs very often with these CMOs is that rules and procedures change very quickly. And all we're asking is when you change those procedures, do them in an organized fashion. Give appropriate notification to therapists. While we were here today, two of the CMOs we've just suddenly got faxes at our offices to tell that therapy will no longer be billed through them, but through some other group called CareMetrics. For 2 days, we've been trying to get the answers to that, and nobody seems to know what's going on. Yet we've gotten faxes that said this is occurring right away. And finally, when you're talking about children's services, some of the biggest issues that are surrounding are those services that are related to the federal guidelines under EPSDT. Those are federally mandated services. There's been a lot of confusion with the CMOs as to medical necessity and as to the provision of those EPSDT services. One of the things that we've talked about way back with DCH is many states foresaw some of those difficulties and actually carved out the EPSDT services. Those were things that I think that we probably knew about going forward, but chose not to do that. That would be one of the big issues that would help at least children under the age of 21 to get services that they so desperately need. Thank you for your time today.
Thank you. Karen Coulter will be followed by Renee Hall.
Mr. Chairman, thank you for this opportunity to come before you all. I applaud you for allowing us to take up the entire afternoon discussing the issues. I think I have yet another issue. My name is Karen Coulter. I am Executive Vice President and Chief Operating Officer of Sherwood Clinical. We are a Georgia-based, independently owned infusion specialty pharmacy. We employ 100 people in the state of Georgia, and without exception, we have patients in every one of your districts. I respect the fact that you all are trying to save the state money, but I want you to understand the impact on the small Georgia business. In 2004-2005, our Medicaid census was at 65%. Last year, with the induction of the CMOs, our Medicaid patient load dropped to 34%. Each of the CMOs use a different criteria. Because of that in their prior approval process, we've had to add employees. I, too, have added 4 FTEs to the amount of $150,000. And if the financial impact was the only problem, that would be an easy fix. Again, with an amended fee schedule, that would, and easier contracting, that would help. But that's not the only problem. The triplets that Dr. McWhorter told you about earlier, Sherwood Clinical was also involved with those triplets in their Synagis administration. And I want to tell you the rest of the story, that all 3 of those triplets tested positive for RSV before the appeal process was even finished. Another situation, Sherwood Clinical was dealing and treating a pregnant woman in Demorest, which is the home where our home office is. She went over, she went over to WellCare. We were not allowed to contract with WellCare. They told us in the very beginning that they were contracted for infusion services with a national provider. There are franchises in the state of Georgia that are allowed under the umbrella of the national contract to provide for them. We aren't one of them. I was told by WellCare that they had plenty of coverage in infusion. This pregnant woman was having complications. I called WellCare. They told me I could not provide for her. They gave me Matria here in Atlanta, and Matria told me they didn't service North Georgia. I called WellCare back. WellCare said call Option Care. Option Care is a franchise of the national provider. I called Option Care. Option Care says we don't take care of high-risk pregnant women. I continued to take care of her and delivered care and services to her without being reimbursed because I thought it was the right thing to do. Again, it was the ethical and moral thing to do. But her therapy, which would have been $125 a day therapy, turned into $1,000 a day therapy because when I called WellCare back, they said, send her to the emergency room. She continued to get anti-nausea medicine and IV fluids in the emergency room. So if they were being offered incentives to keep patients out of the emergency room, that's just one of the examples where I was told to send them there. We also had a call one afternoon from a 43-year-old single woman who had been referred to us. She was newly diagnosed with cervical cancer, had had surgery at a hospital in Atlanta, was coming back to a rural area. She had a hospital-acquired wound infection and was needing 4 to 6 weeks of IV antibiotics. Again, different CMO, was told that this patient had to go with an in-network provider. They had national pharmacy providers. And, you know, my heart bled for her as she asked me for the number to the governor's office. Here is a single mother, cervical cancer, open wound, in need of 4 to 6 weeks of antibiotics, and she was told to drive to the hospital for outpatient twice a day. I could have taken care of all 3 of these with a contract that allowed me, as a Georgia-based pharmacy provider, to take care of them. I ask you to look at the aspects of the Georgia-based small business. I ask you to look at the aspects of the children that are involved, and I can tell you that from my personal opinion is that the CMOs have created a socialized medicine complex system within the state of Georgia. I have documentation here that I have presented to DCH, I have presented to Dr. Nair, that shows it's just documentation over and over and over of the delays in prior approvals and the hassle forms that the Georgia Academy of Pediatricians has asked me. So thank you for your time. I appreciate it.
Rena Hall. Dr. Byron Cawley. And Yvette Samuel on deck.
Good afternoon. Just say thank you for the opportunity to come here and speak today to you on this urgent issue. My name is Byron Colley, and I practice in a second-generation private pediatric dental office in Savannah, Georgia. We have 3 dentists, 33 staff members. Our office has offered continuity of care for private Medicaid patients for 35 years. We've weathered the ups and downs of Medicaid with the understanding that the state would do all it could do to provide a reasonable reimbursement rate for dentists, which results in greater access for children. In the past, the state has used its resources like the Dental Advisory Board and the Georgia Dental Association to ensure that Medicaid system is a success. The state has taken responsibility for any error that may have occurred administratively, and the dentist has been able to practice in good faith. The number of providers since about 1998 has been on the rise, which indicates that the dental needs of our state are more readily being met. There's some serious issues I'd like to discuss with you in the brief time I have. They include eligibility, payment, recoupment for past claims, denials of valid claims, ongoing changes in the provider contracts, lack of cooperation, administrative or their administrators to resolve the issues, and termination of at will of the providers. I want to talk to you a little bit about eligibility. The difficult task of eligibility in our office is a full-time job. We have to get contact numbers from parents, cell phones, addresses. We call them to confirm patients. We call them to make sure they keep their appointments. We send out cards to make sure the patients come to the office. Once the patient comes to the office, or once the patient has an appointment, we check eligibility. And we, in good faith, know that we can provide treatment on that child. However, recently, the CMOs have decided to either recoup money that the child was eligible for treatment or deny claims of an eligible child. This is documented in our system. You're able to print out a eligibility form for the child through Doral, which we were instructed to obtain eligibility for the child. We were never told to check the GHP or the website for the state, which we believe is the most reliable website available. We now find ourselves in a very precarious position. The CMOs currently owe us about $10,000 in involuntary recouped money. We have another $5,000 worth of claims denied due to patient eligibility when the patient actually was eligible. There needs to be clinical accountability by the dentist and administrative accountability by the CMO and the subcontractor. When there's no accountability for confirmed patients, the child received dental treatment, but the dentist has not received due payment for dental services rendered. Recently, one CMO has decided to reduce the rates in our area, the southeastern region, by 25%. This is a significant fee cut for our practice. They have decided to reduce the rates by 15% in the rural areas. Dentists are dropping out daily to see Medicaid patients, and the patients are beginning to end up at our office. And we cannot put another 30 to 50 children on our books to date. We purge our charts every 18 months. We have charts currently of the 8 months in this year. We have 2,007 patients, the year 2007 patients in our chart room. We cannot purge our charts. And this is directly due to lack of access for children. The dental department, Department of Community Health, and the CMOs both have dental advisory boards. There's been no attempt to use these advisory boards to resolve the current Medicaid issues. I'm currently the chairman of the Department of Community Health's advisory board, and the gentleman I practice with, Dr. Jay McCaslin, is on the Medicaid advisory board for Doral. Our office was recently terminated by the CMOs and Doral. After numerous calls, we were then reinstated. We were dropped because of objection to the fee cuts. However, we did write that we would continue to see patients. So they decided to drop us. This is a clerical error, admittingly, but when you're chairman of the Department of Community Health Advisory Board and a Doral board member is dropped at will, I don't understand. With the real fear of more reimbursement cuts, we have to make some changes in our office. We've had to tighten up our schedule and do more treatment at the time of service with parental consent on the children that actually do keep their appointments. Now, some may call this overutilization. We call it taking care of the child that's in our office at the time. If a child comes to our office from St. Mary's, that's a 2.5-hour drive, provided they have no traffic on 95. If that child's in our office and they need 10 to 12 stainless steel crowns due to severe dental decay, we have the time to do it. Our other Medicaid patients have not shown up, or our private patients just decide not to show up, and the parent wants dental treatment done that day, we will do the treatment. We will take the time, administer correct anesthetic, use a papoose board if necessary, and do the dental treatment that child needs. The dental treatment has to be done at some time, at some point. If the dental treatment is not done on that day due to severe dental disease, that the child has severe dental disease, they go back home. They have to make another trip to our office. The potential for infection for that child is real. The pain you heard the principal speak of earlier, the pain that child experiences unable to go to school, the parent misses work, they spend their money on gas, money to get to our office. So we do appropriately treat children in our office and do multiple dental treatments at one time. We think that this is necessary, that it's appropriate, and the more children that come to our office due to dentists dropping out of Medicaid is on the rise. So there will be more claims from our office with multiple dental treatments done. This is a volatile time for Medicaid and peach care programs in our state. We have some major decisions to make. The state has a challenge to provide eligibility to those who qualify. The CMOs and Doral have the responsibility to administer the Medicaid system appropriately, and the dentist has the challenge of meeting the dental needs of the patient. Dentistry in Georgia is facing something we've never faced before. Historically, there was one party between the state and the dentist, like ACS or EDS, to handle administration of Medicaid. We now have 3 for-profit, third-party private insurance companies managing the Medicaid system, plus 2 for-profit dental administrators. By adding a third party in the mix, it appears that there are more Medicaid dollars spent on administration, therefore taking away from the dental needs of the children in the state of Georgia. And I just want to urge this legislators to take this matter seriously for the children of the state of Georgia. And thank you for your time.
Thank you. Yvette Samuel is up, and Angela Smith will be following that. Is that how you pronounce it? Yvette Samuel, Angela Smith, Angela Smith, Catherine Hudson, Catherine Hudson, Skip Wisebaker, Skip Wisebaker, Matt Ryan, Tom Underwood, Dan Powell, Danique Colsey, Melinda Malden, Elisa Ebbett, Marie Teresa Smith, Dudley Harrington, Dr. Claude Simmons. Who are you? Dudley Harrington. Oh, okay, excuse me. Dudley Harrington is now up, and Dr. Claude Simmons, if he's here, will be next.
Mr. Chairman and members of the Joint Committee, I appreciate the opportunity to speak with you today. I'm Dudley Harrington, and I serve as the Vice President of Managed Care and Revenue Cycle for MCG Health System in Augusta, Georgia. And I wanted to speak to you just briefly today, and I'm going to try to stick to my script here so that I don't digress and get off schedule here. But MCG is the second largest provider of Medicaid services in the state of Georgia, and that's largely due to our status as a regional tertiary medical center for neonatal intensive care services, as well as trauma and many other services that we provide to women and children through our pediatric intensive care unit as well. As a result of that, though, we found ourselves in a situation of having to contract with all 3 of the CMOs We are only zoned, so to speak, for 2 of the CMOs, but because of our regional coverage, we have had to contract with all 3. But to prepare the state for CMOs, the Department of Community Health endorsed the management of care approach as a means to achieve the greatest value for the most efficient use of resources. This was proposed as a partnership between DCH, providers, and Medicaid recipients. This concept was centered around the idea that the management of utilization of services would be attained through case management and recipient education. In a nutshell, the goal was to remove routine care out of the busy emergency rooms in the hospitals and, through recipient education, steer it toward more appropriate settings that offered care management. Unfortunately, this has not been proven to be true for our organization. In fact, since last September, when we signed up with the first CMOs, we've actually experienced a 9.7% increase in the number of Medicaid recipients that have visited our emergency room, and that's about an increase of over 200 visits per month since we've signed up. To effect the kind of change, however, that was desired by DCH takes time through patient education and behavior changes. However, the CMOs have ignored their responsibilities in this area as well, and instead this management of care has turned more into a claims denial system. The number and types of denials are overwhelming, and the inconsistencies among the different care management organizations play a major role in these denials. Denials of the month, as we have begun to call them, are a huge drain on the resources of our system. At our hospital, we've had to hire 3 additional staff members to the tune of about $75,000 in actual salary cost plus benefits. But in addition to that, what you also have to realize, those folks are just to get the claims out the door and coordinate the appeal process, but the appeals takes times from our medical records department, utilization review department, often the physician having to take their time to attend to a matter with regard to an appeal. So it's a huge resource drain on our system. And as a result, we are incurring much higher costs to collect at best, in the best case scenario, the same amount of money we got last year. That's not the case. Again, the concept of managing care was to have the proper care delivered in the proper setting. Rather, the result is the denial of medically necessary services due to the inconsistent practices among the CMOs, inconsistent application of DCH policies, and the total disregard for contractual obligations. All of these things have already been discussed today. All 3 of the CMOs approved by DCH were chosen, among other reasons, for their experience in the field of Medicaid managed care. Yet this has not proven to be beneficial for our hospital system, as evidenced by the fact that it took over 6 months for the first CMO to lay out a workable procedure for us to file a claim for high-cost outlier claims. Additionally, we've identified the first claims last September where immunizations and injectable medications were not paid for. It's taken us until July to get some reason as to why these claims were not paid, and we were told it was because we didn't, the NDC number was not included on the claims, but we've put those NDC numbers on the claim and they're still being denied. NDC numbers being National Drug Code numbers. This issue today, almost a year later, is still being researched so that we can determine how we can receive reimbursement for immunizations and injectable medications. Likewise, we've been meeting with CMOs since last fall over their refusal to pay us for charges associated with our clinic visits offered in our hospital. Further, we experienced denials for lack of prioritization for inpatient services, even though prioritization was obtained from the Medicaid payer on file at the time the patient was admitted in our hospital. But sometime during the hospital stay, again, especially with these neonates who have long hospitalizations, the Medicaid CMOs are allowed to change coverage, and so therefore the second CMO that picks up the coverage is denying our claim, saying we didn't receive prior authorization, although we had it obtained from the first CMO or the CMO payer that was on file at the time of admission. And it would seem simple that you would be able to file a denial to the CMO, the second CMO, showing that you had originally gone through due diligence to try to get authorization, and it changed without anybody notifying us. There was no requirement that they notify us as a hospital provider that the coverage has changed, but we still get denied. To date, we've been forced to write off over $1.5 million in related denials, and this is not inclusive of what we currently have in an appeals process. These are actual claim dollars that we've had to write off. The denials are a severe drain on the resources of our hospital and simply cannot be sustained. Either programs will need to be cut or costs will have to be shifted to other payers, or we're going to find more hospitals like Grady. But if we end up having to shift costs to commercial payers, unfortunately, that's going to end up in the laps of local employers and industry. And these folks are already feeling like they're having to pay more than what they have to pay for the cost shifting of care for those who can't afford to pay. And the main concern with that is that with the shifting of these kinds of costs to other payers is that many of the employers are feeling overburdened and by the cost that what it costs them to provide care for their employees. And this has the potential of fostering an environment in the state of Georgia where they may feel disadvantaged by trying to do business here, and therefore could affect our ability to grow our state economically. We appreciate the opportunity to speak with you and hope that we can find some opportunity to reduce the inconsistencies that among the CMOs and their application of the DCH policies. If you have any questions, I'd be happy to answer them.
Thank you. Dan Powell, I'm sorry when I called your name.
Oh, that was my fault.
And Dr. Claude Simmons, is he here? Okay, you next.
Thank you for the moment I'll take. I know I don't get the time that the others passed on, so I'll be real quick. I do want to say that I work for the Metropolitan Atlanta YMCA, and we hold the largest Head Start contract in the state of Georgia, serving over 8,000 kids a day, and additional 10,000 kids in after-school child care programs. And every day we find kids, we work with kids who are experiencing some major dental needs. Childhood obesity is rampant. Sedentary lifestyles are just prolific. And unlike some of the other people here, our work is in the area of prevention. And I just want to simply, I know this sounds like a commercial, and I apologize, but in light of all the other comments, I want to say that the providers are also doing a lot of outreach work. Mayor Group has chosen to be the Atlanta-wise partner in helping in preventive care. 15 years from now, this conversation will be about we can't afford health care anymore. So the YMCA and the providers, the Mayor Group in specific terms, is aggressively working to address childhood obesity, sedentary lifestyles, dental care, and other issues. And I just simply want to say for the record that let's fix the issues we're talking about. Let's try to make a difference in the problems that you guys are encountering and others are. But let's don't throw all that away. Let's just move forward, fix the problem, and let's begin working with the agencies and the providers on prevention as well. But we're real proud of our relationship with the providers and specifically Mayor Group for their partnership on prevention, childhood obesity, and minimizing sedentary lifestyles for children. So thank you for the moment.
Thank you, Dr. Claude Simmons, and that will be followed by Teresa McMillan.
Thank you, Mr. Chairman. I'm actually Clyde Granville Simmons, M.D., with a bunch of other initials after that don't really matter. I'm the head pediatrician in the group. There are 10 of us providers. We have offices in 3 cities, all in rural southwest Georgia. About 70% of our patients are Medicaid, and I've been dealing with Medicaid for 30 years now. We, by design, only contracted with one CMO. That was Peach State. We negotiated our own contract. We don't have the standard contract. As a summary, let me just say that our position is that the current CMO system is better than the old Medicaid system. It needs a lot of tweaking and can be even a lot more better. But let me tell you why. Of course, the obvious first one is I'm getting more money. And that seems paradoxical, but I'm getting more money because I'm getting paid for codes that Medicaid never paid me for, particularly providing care to patients in my office in the evenings and on weekends. Why shouldn't I get paid more? I'm keeping them out of the emergency room. The disease management program with the CMOs is working. The Peach State program with their asthma has helped us. It reinforces what we say to the parents. Sometimes they listen to the guy paying the bill better than they do the doctor in the office. Our asthma admission rates at the hospital have gone down under the CMO. They're a big help with no-shows. We have kids with chronic illnesses who for various reasons don't show. We just let them know, and for some reason they start showing up. I don't know what they tell the parents. I don't want to know what they tell the parents. They provide help with transportation, which we had severe problems with under the old Medicaid system, and other points that have already been mentioned. Let me mention a few other things that need tweaking that haven't been mentioned. The state's auto assignment system is a joke. The DCH will tell you the criteria that they use, but as far as our impression is, their mainframe computer's is hollow and got a monkey in there throwing darts at a sheet of paper. We have people who are switched. We've had patients who've been switched 4 consecutive months in a row, never on the same plan they were on the month before. Talk about disruptive continuity of care. That'll do it. For pediatricians, our main problem is with newborns. If the mother's with one CMO because that's the only one her obstetrician takes, and yet her other kids see a pediatrician who doesn't take that plan, and she wants the new one to be on the plan the pediatrician takes, she cannot pre-assign that baby to another CMO. The baby has to be born, get on Medicaid, be put on her CMO, then she can change to our CMO, which takes at least 90 days. In the meantime, the baby has missed at least 2 and possibly 3 of his health checks. It's a disaster waiting to happen. Some baby is going to have a problem that should have been detected and couldn't go see the doctor. Other points have been made. Let me say that there are holes in the network. Part of the holes in the network in our area are simply because of money. The specialists don't have to see Medicaid to make a living. Those of us in primary care in areas that have demographics that are such do have to see Medicaid. The problem probably will not be fixed till at least the legislature, through whatever mechanism with Medicaid or the CMOs, see to it that the providers are getting at least the equivalent of Medicare. This problem is not going to get any better. There are not enough physicians in Georgia. It's getting worse. The medical schools cannot produce enough physicians. It is getting impossible for us to recruit physicians to come to Georgia outside the state of Georgia, particularly once they find out what Medicaid is paying. We're running into that problem constantly. I think a lot of the problems could be better handled if there was true competition in the system. And I'll just stop by saying that I wish the members of the committee would read a book by Michael Porter called Redefining Healthcare. It's published by the Harvard Business School Press. He's a competition guru. His points, in particular the chapter on government involvement in health care, are very much to the point. Thank you.
Representative Stevens has a question.
Doctor, tell me again, which CMO pays you more?
Peach State.
Peach State, okay.
Yeah, and I was kind of scratching my head wondering what the problem with these, how come other people are having other problems? There is a slight delay. My account receivable days has increased by 7. It was slightly over 21. It's now below 28. National average is 45, so what do I care? I'm waiting 7 more days to get paid a lot more money.
Thank you. Teresa McMillan, and next up will be Lou Imbrogno.
Good afternoon, Chairman and other members of the committee. My name is Teresa McMillan, and I'm here today representing Memorial Hospital and Manor in Decatur County. We're a small rural hospital, 80-bed hospital, and so the impact has been great on our facility. A lot of what you've already heard this afternoon. We have about 16,000 visits in our ER a year. About a little over 3,000 of those are covered by Medicaid. This past fiscal year, we had 338 babies born at our facility. 272 of those were Medicaid. And you've heard all the issues with getting them enrolled, making sure we get coverage for them. One of the main things that we're having a lot of trouble with is getting paid triage fee on our emergency room visits. Now, you know as well as I do, we can't pick and choose what patients we see because of EMTALA. We can't screen them out because of liability issues, and we're getting paid $50 a hit for those. When this first started, the issue came, well, who's going to appeal them? We're a small rural hospital. Where's the help going to come from to write all those letters of appeal, make the copies of the records, get the work done? So I personally work nights, weekends to get that done just because there was no one else there to do it. Since March, I've appealed 58 of those. I've got 0 overturned, still stand. I get a letter saying we're standing with the $50 fee that we paid you. The amount of those charges were about $34,000. Now, we're a small rural hospital. The impact is great. In our emergency department, when the patients come in, we've had several asthma patients. They come in, you've got to have IV access, you've got to do chest x-ray, you've got a mother bringing that child that's having a difficult time breathing. We got to take care of the patients. What we're doing is getting paid $50 a hit. We had one young girl, 16 years old, came in right lower quadrant pain. Is it appendicitis? Is it a kidney stone? Is it a cyst? What's going on? She's also a diabetic, which complicates matters significantly. Total bill on her was a little over $3,000. We got paid $50. And we appealed it. They stayed with the same. We're going to pay you $50. The $50 have added up to where it's really hurting. Another couple of issues that we have is that the notification, we have to notify within 24 hours that these patients are even being seen in the emergency room. So you've got staff, extra requirements of your staff to do all of that notification. You know as well as I do, the age of the patients we're seeing, parents have got to have their children seen, and we're there to provide care, and it complicates it when you're dealing with diagnoses like we are in these children. When we call, we need an MRI, we need CTs completed on an outpatient basis. They used to tell us 30 days prior approval. Now we get 7 to 14. But still, if you had a child yourself that had something urgent going on, you would not want to wait 7 to 14 days to wonder if it's something life-threatening. We got to have some help with the system, and we got to have help with the administrative part. All the notifications, they want notification within 24 hours, turnaround time when a baby's born. They want to know within 24 hours if they've been at our facility, but how long does it take for them to get back with us on prior approval? It's got to be reciprocated somehow, and we need your help from the committee. I thank you for your time, and anything you can do to help us get through these issues would be great. Do you have a question? Any questions?
Yes, Representative Henson has one question.
Thank you for your presentation. We've heard innumerable times today about the $50 reimbursement fee in emergency rooms. Could you give us some idea, and I know it's going to be difficult because you have to run so many different tests, but just like administrative work and just regular processing, approximately what is that costing your hospital?
If I have to take the time to write one letter of appeal, get the copy of the medical record, you can do several a day if that's your only duty. But it's not the only duty for most of us. So for me, when I was doing it myself, doing it on nights and weekends, I could do 6 or 7 a day if that's all I had to do. So you talking about, and we've got an RN that's doing that now. I've had to hire 2 full-time employees since then. So in the past 30 days, I've got one that'll be starting next week, and I've hired one previously.
So let me see if I can follow up on that. You are hiring RNs to process paperwork as opposed to actual patient care because of the increased paperwork that's come about since we put the CMO system into place?
That's correct.
Thank you very much.
Thank you. Lou and Bromno and Dr. Darrell Smith will be up next.
I'm speaking today on behalf of VHA Georgia, which is a cooperative of approximately 50 large not-for-profit hospitals, or predominantly larger not-for-profit hospitals in Georgia. VHA hospitals understood and accepted and also supported the state's decision to implement a Medicaid managed care program. As Kathy Draegers reported earlier today, a major premise of the successful implementation of a Medicaid managed care program is effective medical management. Effective medical management would reduce demand for services, channel patients to less expensive care settings, avoid unnecessary testing, and assist patients in better managing their health through improved compliance with doctors' orders and good health habits. This effective medical management would be expected to result in hospitals providing fewer services and receiving less reimbursement. VHA hospitals accept that reimbursement would drop under Medicaid managed care, but expected this would be associated with a reduced volume of services. Our hospitals accept that they will lose money caring for Medicaid patients, and we want to perform our share of Medicaid care as part of our mission and community obligation. Thus, a program that results in less Medicaid volume would not necessarily be expected to be problematic or cause significant problems. If the volume of Medicaid services drops, hospitals can save certain costs almost immediately, drugs or supplies or things not used. Certain other costs like labor or equipment will take longer to reduce, but if the volumes are reduced over time and sustained, they can be reduced as well. But the idea of getting paid less for performing fewer services seemed much more desirable to us than having the state have to make arbitrary cutbacks for providing the same amount of services. The worst case scenario was seen as the state just making those kind of cutbacks with no chance to realize efficiencies by providing fewer services. This would amount to taking an already unprofitable patient population and simply increasing the loss. It is with this rationale in mind that Georgia VHA hospitals entered into the Medicaid managed care program. We saw this Medicaid managed care program as a value equation. The CMOs get awarded large populations by the state with reimbursement based roughly on previous utilization and fee levels. The CMOs significantly improve medical management, reduce utilization of services, and earn a healthy profit. The hospitals receive less total reimbursement, but are able to benefit somewhat by decreasing their expenses along with this. The reason why I'm here today on behalf of VHA Georgia, however, is that we don't believe that value equation is working. And we don't believe the CMOs are really being accountable for their performance. A summary data of 23 of our facilities shows a reduction in total visits of 2.8%, but a corresponding reduction in reimbursement of 12.2%. The comparative time frames are September 2005 through April 2006, compared to September 2006 through April 2007. When annualized, this 12.2% reduction represents a $67.5 million drop in reimbursement, when we would have expected a drop associated with a drop in volumes of 2.8% or $15 million. So that's in excess of $52 million more than expected. Unfortunately, this $67.5 million reduction does not reveal the full story. Each of the VHA hospitals has had to dedicate substantially greater amounts of staff to administer its CMO contracts. These costs have risen dramatically as reimbursement has fallen. And there are many reasons why facilities have been paid less than expected that aren't associated with a volume drop. And I won't go into great detail because so many people have talked about these problems prior to me. They include the $50 triage fee, failure to configure facilities correctly in CMO's claims payment systems, just simply paying the wrong amount due to administrative errors, significant delays in loading of providers where they appear out of network when they're under contract, inability of CMOs claims payment systems to administer the contract reimbursement appropriately, new and burdensome payment rules and changes to these rules over time, as well as requirements for reporting clinical data that has no meaningful impact on medical management of the patient, but when not reported results in lost reimbursement. The underpayments and denials that resulted in our substantial reduction in reimbursement do pose a huge burden for processing the appeals and trying to correct payments. One of our member hospitals reports needing to hire 9 additional full-time staff just to deal with Medicaid denials of one CMO. The normal response of our hospitals when these types of problems occur with a commercial payer is to enter into termination proceedings and potentially renegotiate contracts. In the case of the state's Medicaid managed care program, however, most of our hospitals have little leverage that they can exercise. If they exit their contracts by state regulation, all CMOs can automatically pay them 90% of Medicaid, and that is if the CMO approves the service. After a year of struggling to work through our issues with the CMOs, and what we believe is a remarkable lack of progress, we have reached the point of our testimony today. Our biggest fear, and I would underline, our biggest fear is that increased losses on this population will result in cutbacks in service for those who can least afford their care. We are also concerned about having to shift the deficits from the Medicaid population, and they are increasing beyond the point that we can tolerate, shifting those deficits to commercial payers, which will artificially drive up commercial rates and make our state a less competitive place in which to conduct business, and possibly force some employers, particularly smaller ones, to drop their coverage, and this will only increase the state's Medicaid burden. What are we asking for? We're not asking to rewind the clock or terminate the Medicaid managed care program. We are asking for support in making the value equation work by holding the CMOs accountable for their performance. We all have a lot at stake here. We want and need the CMOs to be successful and profitable, but by effectively managing the Medicaid population, not simply shifting money from the hospitals to their bottom lines. We ask to be included in the dialogue with the state and the CMOs to address and resolve these issues and hopefully do so in an equitable and timely fashion. And I thank you for your time and for the hearings that you're holding, and hope that improvements will be coming in the future.
Thank you. Dr. Darrell Smith and Jamie Chesson is up after that.
Good evening, Mr. Chairman and distinguished members of the subcommittee. Out of respect for future speakers, I'll keep my comments brief. Thank you very much for inviting Help a Child Smile to appear here today. I'm Dr. Darrell Smith, the Group Administrator for Help a Child Smile. I have been with them for over 10 years. Help a Child Smile was founded in 1993 by Dr. Mark Charette, a practicing dentist in Conyers, Georgia, for the purpose of delivering quality health care to Georgia's children. Since its inception, Help a Child Smile has used mobile units to administer dental services at distinguished school sites throughout the state of Georgia. Through these mobile dental offices, Help a Child Smile has been able to focus its practice on delivering dental care to children who do not or cannot regularly visit a dentist. Help a Child Smile has been in continuous operation in Georgia since its founding in 1993. Since then, Help a Child Smile has provided quality dental care to nearly 150,000 of Georgia's children. As you know, in 2005, the state of Georgia, through the Department of Community Health, implemented reforms to the Medicaid and Peach Care for Kids programs, through which Georgia delivers medical and dental services to adults and children based on economic need. Upon completion of these reforms, the state of Georgia began administering both the Medicaid and Peach Care for Kids programs using a statewide full-risk care management system. The department selected 3 CMOs to administer the Medicaid and Peach Care for Kids programs, and Help a Child Smile was heavily recruited by the CMOs and their third-party administrators, Doral and Avisis, to join the networks and to deliver dental care to Medicaid-eligible children. Help a Child Smile has been a provider in each of the networks since its inception of June of 2006. We currently serve patients at over 640 schools in 76 school systems in 68 of Georgia's counties. In 2006, Help a Child Smile successfully treated over 48,000 patients statewide and over 68,000 encounters. Our unique method of delivering care makes it a critical component in the state's delivery system to ensure that both access to and actual care are available to eligible children. By delivering care on-site at elementary and middle schools throughout Georgia, Help a Child Smile is able to treat children who are not otherwise able to see a dentist, perhaps because their parents do not have transportation or are unable to take off work to seek dental care. Help a Child Smile has received widespread support from school nurses and community representatives who have praised Help a Child Smile for making dental care available to those who do not otherwise have access to it. There's been some upheaval in the last few months regarding the dental network in Georgia. We've heard a lot of that today. Our primary goal has always been and continues to be to provide quality dental care on an uninterrupted basis to tens of thousands of children that need treatment. Help a Child Smile continues to be a participant in the AmeriGroup network. Help a Child Smile's participation in the WellCare Dental Network has recently been extended, and we are working with WellCare to reach a mutually beneficial long-term agreement. Finally, Help a Child Smile is having productive, positive conversations with Peach State on a long-term agreement and is optimistic one will be reached shortly. Help a Child Smile is very excited to be able to continue providing quality dental services at school sites throughout the state of Georgia without interruption and looks forward to reaching long-term agreements with WellCare and Peach State. We've heard a lot of commentary today by a lot of knowledgeable individuals who have preceded me, but again, our primary overriding goal, and I believe the shared goal of all of Georgia's conscientious providers, is to continue providing quality care on an uninterrupted basis to tens of thousands of Georgia children that need this treatment. Thank you.
Now, Dr. Smith, one quick clarification. I'm
Yes,
sure
sir.
I understood what you said. It's my understanding that your company had received termination notice from WellCare and Peach State. Did I understand you say that now those discussions are now ongoing? Is that what I heard you say?
That's correct. We have an agreement for an extension from WellCare, and we are currently in discussions with Peach State, and we are optimistic that we will have a satisfactory resolution to extend our contract with them.
Thank you.
You're welcome, Representative Chanel. Thank you.
Jamie Chesson. Sherry Mitchell. Sherry Mitchell. Liza Hunt. Liza Hunt. Brooke Todd. After Brooke Todd, Dr. Mike Carr is up.
My name is Brooke Todd, and I own a small pediatric therapy company in Gwinnett County called Children's Therapy Group. And we provide pediatric speech and occupational therapy. We do have contracts with all three of the CMOs, and these are a few of the problems, obviously, we've talked about today that we're experiencing on a much smaller basis. Increase in the number of denied services based on the CMOs not finding services medically necessary. A decrease in the frequency and length of services approved that are recommended by physicians and therapists, and an increase in paperwork and documentation needed. Despite having contracts with the CMOs, we are being paid at less than 100% of the Medicaid fee schedule. The main point I'd like to make today, I'm going to try to make it quicker, is that we are experiencing some significant downfall in the Babies Can't Wait program here in Georgia, which, if you're not familiar, is the early intervention agency that provides services to children birth to 3. It is, in my opinion, that these problems that we're seeing in Babies Can't Wait are directly affected by the CMOs. Babies Can't Wait is designed to be a payer of last resort, meaning that all other payers must be tapped before we can bill our services to Babies Can't Wait. And due to the increase in denials by the CMOs, we are having to bill claims to Babies Can't Wait at a much higher rate, which I feel is slowly draining the Babies Can't Wait budget. I have 3 suggestions, what I think everybody's talked about today, to help ease some of the problems for providers and help the situation for our patients. There needs to be a uniform medical review standard that all CMOs are using to base their guidelines for approvals or denials. There should also be, in my opinion, fines faced by the CMOs when they are not upholding their contracts and breach of contract and not paying providers at 100% of the Medicaid fee rate. And there also needs to be an increased number of field representatives at the local level by the CMOs to help provide support to the providers here in Georgia. It's been difficult as a provider and a business owner to watch quarter after quarter as the state of Georgia continues to report record revenues and savings from the implementation of the CMOs, and we struggle to stay afloat financially. Not only do we have patients that are enrolled in the CMO program that are suffering, I'm finding that there are going to be problems with other children not enrolled in the CMO programs through the Babies Can't Wait programs and their downfall. In closing, I'm a therapist, and that's what I do. I don't speak in front of people like this very often. So what I do when I do therapy is I try to show my children situations and things that help them to understand what the concept is. So for you today, I give you this example that think for a minute that your position here with the state, you're paid $2,000 a month, hypothetically. And the state comes to you.
Yeah.
Okay. Hypothetically. The state comes to you and they say, you know, we have this new program that we'd like to implement, and we think it's going to help save some costs in your department. And the program's going to require you to do additional paperwork. You're going to spend some additional time at work, and you're going to have to figure out what to do when there are problems on your own. You don't think it sounds too bad, so you sign a binding contract. And the first month comes, and you receive your paycheck for $1,500, which sounds great, I'm sure, some people. You question the state as to why you're receiving less money for the same job that you have done for years. Plus, you are receiving less money for additional paperwork, and you have signed a contract that says you are supposed to receive $2,000 a month. But the state urges you to press on. Please continue to provide those quality services. Do that job that you've done for years. We'll fix it. The program tells you that there are now new guidelines that you must go through to get your paycheck. The second month comes and the state says, we don't have your check ready right now, but hold on, we'll have it ready for you soon. You're told by supervisors not to ask questions, and you continue to do your job. And finally, the state issues you a check 2 months later for $1,000. Yes, you had to wait an additional 2 months to get paid, and yes, it's half of the amount that you were previously paid when the program was not in place, and you signed a contract. But you must continue to press on because you have citizens that count on you every day to provide a much-needed service. Imagine going through this scenario in real life over a year now. And as a provider under the CMO program, that's what we've been going through. If you could just put yourself in our shoes for a minute, I think you'll see that we feel we're being sacrificed for the benefit of saving money for the state, and also at the expense of the people that depend on us to provide services that they need. Thank you.
Thank you. Dr. Mike Carr. And will be followed by Shelley Mack. Shelley Mack.
Thank you, Mr. Chairman and members of the subcommittee. My name is Dr. Mike Carr. I am a general dentist in southwest Georgia. I have 2 practices, one located in a small town, rural town in Donaldsonville, Georgia, and one that's in Cuthbert, Georgia. I'm here today to tell you that the dentists in this state are extremely frustrated, disappointed, and scared about the current Medicaid system that we're under. Our program is not supposed to be this difficult to deliver dentistry. We now have these issues facing us. We have recoupment, subcapitation, provider termination for no reason, fee cuts, radiographic bundling, limitation on services, standard of care issues, fraud and abuse issues, and tactics by the CMOs, and the list goes on and on forever. I want you to know that access, which has been talked about several times today, there truly is an access problem. And the reason I say that is the state has identified what they call significant traditional providers. There was 400 dentists who are providing 80% of the Medicaid dentistry that's done in the state. That number is now down to 300 dentists. And in terms of access, we need to really look at who is doing the dentistry. You may have a large number of dentists on the rolls, but that doesn't mean that they're doing a significant amount. Only those 300 dentists are doing that. The model for dental care in the state of Georgia goes like this. We have corporate dentistry. We have the van dentistry, which Help a Child Smile spoke a few minutes ago. We have several dentists who are participating in group dentistry that deliver that care, and we also have dentists like myself or individual providers. And that's where most of the dentistry is being done in the 159 counties in Georgia, is by general dentists, private dentists. Most of those dentists that are participating are doing anywhere from 60% Medicaid to 100% Medicaid. Your corporate dentistry, your van dentistry is almost 100%. A lot of your group dentistry is 100%. Private dentistry, like myself, is around 60 or 50. There are no other dentists that are doing dentistry. There are no dentists that are doing 10% or 5% or 20%. Those dentists have left the program. They're gone. It's not worth it to them financially to participate in the program. It's too much of a management nightmare. It's impossible. They can't survive. So only those groups that are highly efficient, who have highly trained staff, can manage this managed care system that we've got. And I want to tell you that I've been doing it for 30 years continuously, and I've never been in a situation that I'm in today with the business model in a small town trying to do dentistry and trying to survive under the Medicaid system. So much so that I'm almost anticipating closing one of my offices and buying a fee-for-service practice. Today, as we speak, I'm negotiating for that. So that's how threatened I am of this system. There is an eligibility issue. You've heard comments about that. Eligibility, we've been told, can change daily. We never know where it's right or whether it's wrong. We never know if the portal's right. We don't know if the CMOs have the correct information. We just don't know. I'll give you an example. A mother and a child presented in my office for 45 minutes. My staff, this was at 9 o'clock in the morning, tried to determine eligibility on this patient. GHP said they were eligible. The CMOs said they weren't. The subcontractor said they were not. The mother said they were. We went round and round. My staff called all three, or tried to contact all three. Unable to do that for 45 minutes, that child sat in my office with me ready to provide dentistry for them. End result, we handed the phone to the mother. The mother called the subcontractor. In 30 seconds, a key was punched, and that patient was eligibility in my office, and we went to work. That's the types of things that we have to go through on a daily basis to provide dentistry. So eligibility is an issue. We used to have 30 days where a patient was eligible. Now that eligibility may change daily, as I mentioned. Utilization has been spoken about. In my own practice, I've become extremely efficient. ACS made me so electronically savvy $50,000, $60,000 worth of electronic equipment to try to manage the paperwork flow from these CMOs. And so most of the practices in the state that are still functioning today are extremely efficient. And that's why utilization, one of the reasons why utilization is up. Utilization is up in my own practice. In order for me to survive, I could not get an oral surgeon to see my patients in Southwest Georgia. So what I did was I invested in oral surgery equipment, and now I have an oral surgeon that comes to my office 2 days a week and sees my patients in my own facility. So my utilization's up in my little small practice. So yes, utilization is up, but the reason it's up is because we've all become extremely efficient, and we know how to produce the dentistry and look after the children of this state in an efficient manner. The closest pedodontist to my practice is 100 miles. I have to send children from Donaldsonville, Georgia to Valdosta, Georgia, halfway across the state. WellCare, because of their current policy issues, I cannot find a pedodontist in Valdosta anymore. They are not receiving or not giving care. And I just told you about the oral surgery issue, what a problem that is. So I had to create an oral surgeon situation for my own office. One thing I want to mention to you about pedodontic referrals, and when you see what's mentioned about how many stainless steel crowns are done on children that we refer to pedodontists, I don't see a child in my office that's, say, younger than 5 years old. Most of it is a management problem. I'm just unable to see those children, so I refer them to a pedodontist. Most of the time what happens is they do maximum amount of dentistry in that visit because they have to travel 100 miles to seek care. When that patient is returned to my office and I see them on a 6-month recall, I generally don't have to do any other treatment for that child for years. Sometimes it's 10 years. It's just a matter of cleaning their teeth, doing checks, and watching those baby teeth and possibly erupt.
Dr. Carr, would you clarify for me again what I thought I heard you say? You mentioned 400 dentists doing 80% of business at some point in time, and then now 300 doing 80%. Would you go over that again?
Yes, sir. The state identified before the CMO model was put into place, that there were 400 significant traditional providers, which means that they were doing a significant amount of dentistry. These were providers that were identified by the state prior to the CMO model. They were doing a significant amount of dentistry, and they had traditionally done it over a long period of time, like myself, for 30 years.
When you say a significant amount of dentistry, you mean as it relates to Medicaid patients?
Yes, sir.
So
yes, sir. They were doing 80% of the Medicaid dentistry that's done in the state.
And that was when? Those 400? What year was that?
That was prior to the CMO model last year. So 2004.
And you brothers say that there are now 300 dentists
that's
doing
what,
80%?
That's what I understand, sir.
Where'd you get those numbers?
That number has been talked about in the dental profession quite a bit.
Ms. Driggers, would you have a comment on that? Can you find that out for us? The dentist doing 80% of the business? That sort of punches a hole in the flag in the map thing, doesn't it? Ma'am?
Currently, this is for Peach State and WellCare. They have 944 providers at 735 locations. WellCare has 947 providers at 744 locations.
Well, what he's speaking to is what I referred to earlier this morning about who's doing the business, not just somebody doing it, but...
These have all been verified that they are doing the business.
But could you provide us information on, could you verify that 300 dentists are doing 80% of the procedures?
What Dr. Carr is talking about is there are, we did identify before we went with this program that the significant traditional providers, we did identify those providers in several big categories of service: hospitals, pediatricians, OBGYNs, behavioral health providers, including dentists as well as pharmacists. We identified the top 80% of providers that had provided care to Medicaid in those big categories of service. And we call them significant traditional providers. And we directed the CMOs to include them in their networks for the first 2 years of the program, provided that the providers agreed to accept the reimbursement and abide by the contracts, as well as they pass credentialing. So that's what he means by the significant. He's very right about the significant traditional providers. The 300 that are left of the 400, that I don't know where that comes from. These are the current dental networks.
Do I recall that we have some 2,000 total dentists in the current network? Is that correct?
In fee for service?
No, in the CMO network. How many dentists do we have?
In the Peach State network, they use Avisis as their dental subcontractor. No. They have 944 dental providers at 735 locations. In WellCare has 947 providers at 744 locations. This is very recent, as of within the last 2 weeks.
So that's 2 out of 3. What's the other one?
I don't have AmeriGroup with me.
So, I mean, those two alone have almost 2,000, according to your numbers.
They're the same dentist. They're not unique. They're the same dentist. In other words, Peach State and WellCare have very similar networks.
Could you, well, again, I guess my point, or where I'm trying to get to here, is that whatever number we have, pick it, it's 1,800, 1,500, 2,000. If 300 of them are doing 80% of the business, I mean, that is a significant statistic that this subcommittees, the two subcommittees, I can assure you, are very interested in terms of access.
There is absolutely the case that within any category of provider, that some providers are going to be doing more Medicaid business than others. You've heard other providers of other types talk to you today and talk to you about some of the hospitals. Some are significant Medicaid providers, as Grady, Children's Healthcare of Atlanta, MCCG. Some of the therapy providers. That is true. There are some providers who do more Medicaid business than other providers.
Well, would you not agree if that is anywhere close to being correct? If those 300 were removed from the network for whatever reason, and they can do it for no cause, I mean, wouldn't that have the effect of wrecking the network, even though there is somebody somewhere says they'll take them?
Absolutely. That is why when I talked to you earlier today, we do verify that there are providers who are willing to take, and that's one of the things that we're checking all the time, is that there is access and capacity.
Well, I think the larger point is beyond willing to take, are they people who are actually treating a significant number of patients? That's
no question about that.
Thank you.
Mr. Chairman, I was one of those dentists that was terminated at one point, and what I did was I sent in a letter objecting to the fee change and the policy changes. I was not contacted by any member of Doral nor Avisis, and the next letter I got was termination with no reason. And so the point I want you, it was asked by one of the committee members this morning about notification, and I have several of my colleagues that fall into the same category that objected by our contracts to the fees and the policy changes and asked for someone to contact us to negotiate, and to this day that has not happened. Some of the terminated dentists have been reinstated, some have not. So in terms of termination, that's the kind of process that we've been under. I want to tell you about just a few more things.
Yes, sir. We are running very short on time, sir. You have a very interesting story, but you've been up there about 10, 12 minutes already.
All right. I'm sorry. Prior approvals are a problem. A management nightmare, which we've already talked about. Doral is an extremely good subcontractor in terms of the way they manage their business. Avisis is not. Avisis is trying to reinvent the wheel. They know nothing about dentistry and everything about optical care. The only solution to this problem is for us to consider some type of carve-out in the near future so that we can survive in dentistry. I thank you, sir.
Thank you. Salil Mack, if I'm pronouncing that right. C-H-E-L-L-E, Mack. What's that name? What's your name? What? I'm sorry, you Lisa Hunt? Okay. Go ahead. Just give me Cecile Mack, I suppose, is not. He is Tamika Smith. Is Tamika Smith here? Doug Wilson. Dina Zika. Excuse me. Okay, Doug Wilson will be up after you, ma'am.
Okay, thank you. Thank you, Mr. Chairman, and thank you to the committee members who have extended their day for us in respect of the time we took to travel. That's greatly appreciated. My name is Lisa Hunt. I'm the practice administrator for White's Pediatrics. We are a rural-based primary care pediatric practice with locations in Whitfield, Murray, and Gordon counties. I am also a registered nurse, and I have been working with the young population of North Georgia since 1985. White's Pediatrics operates under the direction of Dr. Jeffrey White. He has been a Medicaid system participant since 1982. During those many years of participation, we've seen a lot of transition and have some very notable battle scars that we have received along the way. I would like to point out to this committee that our transition into the CMO system does not compare at all to the transition from EDS to ACS, and there are many things that we're grateful for that has worked very smoothly. Our practice does not put any restrictions on the number of Medicaid patients that we see. We have had as much as a 70% population of Medicaid in our practice. Currently, we're at 62%. And unlike some of the medical practices, we are not allowed to debate the processes and reimbursement rates from the non-participation standpoint simply because of the demographics in our community. Therefore, what we rely upon is maximizing the benefits that are afforded to us. Since the onset of the Medicaid CMOs, we've experienced a positive change in our system operations. Most notably is the change that we've experienced in working relationships. We have transitioned from calling the 800 number at the Medicaid office to speak to the mystery person to actually having direct representation for our area and our district. We are now on a first-name basis with our CMO representatives, and we have methods of contacting them either by email, telephone, or cell phone. Questions and concerns that we have had have been handled quickly and more efficiently than ever. This personalization, we have also noticed, has been extended to our patients. An example is with the Amerigroup Corporation, who has gone above and beyond in community efforts to make themselves available to our patients, to educate them on the changes and what their expectations should be. In addition to that, our community is 50% Latino. To meet this demographic challenge, Amerigroup has provided us with a bilingual representative. So in addition to the benefits that we've already mentioned, our patients feel a sense of trust and comfort in being able to communicate in their native language. We understand as well that all the CMOs offer this service via a telephone. However, the advantage of having someone as a personal contact has been very beneficial for us. As well, with the Amerigroup, they were invaluable in easing the pain of the contractual transitions away from ACS and into the CMO networks through the educational efforts that they directed towards the community, the participants, and the medical providers. Our staff was familiar with all the aspects of patient processing, the use of the web portals, the claim submissions, and the expectations by the go-live date of October 1st, 2006. We were also well pleased to see payments secured on the following week. By comparison to our experiences with ACS, we have taken up to 16 months to credential a provider in the old system. With the new system in the CMOs, particularly with the Amerigroup, we've credentialed in 2 to 4 weeks. We want to share our disappointment with the outcome of Senate Bill 109 that would have required third-party administrators to adhere to Georgia's prompt pay bill. This law passed the Senate 48-1 but died in the House Insurance Committee. Timely payments directly relate to our ability to disperse practice revenue. It is difficult for us to front the staff and the physician's salaries, the medical supplies, the medication therapy for our patients. These costs rise annually due to inflationary changes. We're not authorized, as I think some other members have expressed earlier, to penalize the insurance companies for slow payment, yet we are required to absorb the penalties resulting by their actions by assessing late payment penalties from our vendors or banknotes as we wait for the insurance companies to act. So on behalf of the primary health providers in the state, we ask that you continue to develop enforceable mandates that require the third-party administrators to pay timely, thereby ensuring our financial stability for your medical providers. As well, we recognize and appreciate your efforts to form a committee to address this issue in your upcoming session. In relationship to timely payment, my experience with the CMOs is far more positive than that of some of the private pay companies that we deal with. Perhaps this is because there are consequences for violations. In fact, if we electronically submit a clean claim to a CMO by Friday afternoon, we are receiving payment by the following Tuesday. We are able to estimate the monies that are due to us by the CMOs, and our practice budget is essentially forecasted based on the CMO revenues. There was some question earlier as to denial rates, and I would be happy to share what we're experiencing through WellCare Corporation. We have a 7% denial rate, and with the Mayor Group we have a 3%. We find that to be far in excess of what we experienced in the old system. As you're aware, the Medicaid rates that were reduced by 6% in 2002 have not been increased. Medical practices have been forced to absorb these costs, as well as the transitional cost of each Medicaid contract change. In addition, we're required to pay our staff to complete paperwork involved in assuring that other subspecialists, hospitalists, and outpatient centers are paid for their claims. In summary, we're being paid less each year, and we're forced to increase our staff volume while fighting inflation and fighting the shortage of qualified healthcare workers. In your upcoming session, you will consider House Bill 84 for the fiscal year budget 2008. As you consider this bill, please make note that the Georgia Medicaid primary care providers are being paid 68% of the Medicare rate. The projected increase would raise our rates to 85%. White's Pediatrics would like to associate themselves with the recommendation of 100% of Medicare rate reimbursement that was proposed by the American Academy of Pediatrics. If the state agrees to this increase, we would like to request that the full increase that is given to the CMOs be passed directly to the medical providers. On behalf of the providers of White's Pediatrics, we applaud your efforts to establish a Children's Code Commission within our state. We understand that this commission will be comprised of 20 persons who, outside of legislative representation, will be experts in child health issues. One such issue that is of great concern to our practice is childhood obesity. That being a cornerstone disease is an issue that continues to grow at alarming rates. In addition to this, we've noticed that the CMOs have put practice into place to work on these through obesity committees and Mayor Groups. I believe it's called Power Zone, which I've seen out in our community, in our schools, in our parking lots, and the education is getting out into our community, and that's greatly appreciated. Thank you for your continued support of the CMO network and providing the care to the indigent children of Georgia, and we applaud the time and attention that you as legislators have given us to be heard on these issues. Thank you.
Thank you. Doug Wilson is next, and Dr. David Strange is up after that.
Chairman, ladies and gentlemen, thank you very much. My name is Doug Wilson. I'm the CEO for University Health Link, which is an operating unit of University Healthcare System in Augusta, Georgia. Our system, as many have talked about throughout the day, has had to allocate additional resources for the administration of the CMO transition from the traditional Medicaid program. And our organization accounts to 3 FTEs. And I think one of the key points that we've heard with the addition of these resources in all the hospitals, dental offices, ancillary providers, physician offices, none of this is adding one single benefit to the enrollees in the Medicare program. They're just adding administrative dollars onto the providers. At University, the increase in staffing has come from 2 primary sources. Both I've related in the materials in front of you specific to requirements under the request for proposal. The first and foremost in our situation is that in accordance with the specific web requirements that are outlined, the CMO's website shall be functionally equivalent to the website maintained by the state's Medicaid fiscal agent, which I think you've heard throughout the day was well conceived and well operating before the CMOs came into existence. Specifically, and they're not delivering consistently on functionality, including claims submission for secondary claims, claims adjustments, claims voiding, CPT lookups, claim and line item denial detail, and so forth as we go forward. The second item that's causing concerns for university is the fact that we're getting caught with timely filing situations, and specifically in the reference to the RFP, it states that providers have an obligation to submit claims in a 120-day or 181-day time parameter unless the CMO or its vendors created the error. And what we're finding is we're finding ourselves being caught in situations where the errors are indeed the CMOs, and yet they're still denying claims based on timely filing for us as providers, including the issues surrounding web functionality, as I've already talked about. Valid modifiers are not being loaded into the systems, contract load delays, which you've heard about already today, incorrect rate loads, inability to process claims modifiers, and so forth. One of the things I was doing as we were hearing folks today, you hear a number, consistently hospitals are spending $150,000. That seemed to be the number of the day in increased cost. If we apply that out to the 174 hospitals active in this state, that equates to an amount of $25 to $30 million in additional costs that have been added. If one would treble that based on physicians, increased administrative costs, ancillary providers, and dental providers, we could easily get up to $100 million in additional administrative costs that have come to providers. And that certainly should be offset against the savings that you've heard about today, where the state has saved $248 million. There's an additional dollars that are falling right on the backs of providers at the same time that our reimbursement rates have stayed the same for several years in a row. Thank you for your time today, and we appreciate you taking the opportunity to listen to providers this afternoon.
Thank you, Dr. David Strange, and Dina Zinko will be following that.
Mr. Chairman, my name is Tu Tran. I'm with Dr. David Strange. We're representing the same company. I'd like to share with you my story, and if I could, a Medicaid success story I'd like to share. I am the youngest in the family of 7. My family and I immigrated here in 1975 following the Vietnam War, and settled in Denver, Colorado, where I spent 25 years growing up. And my father died when I was 12, and so my mom was left to raise the 7 of us, and she did a pretty good job. Found it tough, but relied a lot upon public assistance to be able to manage our way through. And so we grew up on Medicaid, all of us. We relied on food stamps to get food on the table. We lived in low-income housing, and to this day my mom still lives in low-income housing because that's all she knows. That's where her friends are and her churches, and you can't drag her away from it. So I know it very well. I was very fortunate enough to become a dentist, and I swore to myself that after I graduated that I had to give back all I could to this great country that did so much for myself and for my family, gave us so much hope and so much opportunity. And I said the way to do that is to provide as much high-quality dental services as possible to the people that need it the most. And evidently that's the people, that's the children who are in low-income situations. They need it the most. And so I started Cool Smiles in 2002, which is a dental company which happens to also be the #1 provider of Medicaid dental services in the state. Very, very proud of that fact. At this moment in time, I'd like to hand it on over to Dr. Strange.
Thank you, Dr. Tran. As Dr. Tran said, my name is David Strange. I'm a board-certified pediatric dentist and been a pediatric dentist for 10 years experience now, although it seems like more. And when people usually say that, they don't say it in a positive sense, but I say it in a positive sense because I have a little bit of a family history too. You see, my dad is a pediatric dentist also, and I grew up watching my dad practice pediatric dentistry on children, providing services on children who were also on Medicaid. And it wasn't until I was older, a few years more mature, that I realized and recognized how important it was to my dad and to those patients to provide that high-quality dental care to children on Medicaid. As my father was my mentor and somebody that I looked up to growing up as a child, he instilled in me two very specific things. One is a desire to treat those patients, and also a desire to train other dentists to do so and to have the same fire and the same passion that I share with not only my friend, confidant, colleague, and classmate, Dr. Tran. And I mentioned all that history, and I appreciate the opportunity for y'all to listen to that history that I mentioned, to say I'm in that role now here at Cool Smiles, where I'm both able to treat children, providing clinical dental care or providing clinical dentistry to those children, and also oversee a fine group of dentists that I'm very proud to be associated with at Cool Smiles. There's two key words that have been discussed here today. Those two words are quality and access. And I want to very briefly discuss what those two words mean to me as a dentist, healthcare provider, and to my patients. I share similar concerns that have been mentioned today by the dentists that have come before us with the difficulties that we've encountered working with the CMOs. So I share that sentiment. I also share similar comments and feelings that were mentioned earlier about my inability to understand how reducing dentists from the network will result in adequate access. I heard a mention of Grady Memorial Hospital being a large provider of Medicaid, and I equate that model, Grady, to the Cool Smiles model. We're the largest provider of Medicaid dentistry to this state and to the underserved children in Georgia, and I kind of imagine life without Grady or Children's as it would be with Cool Smiles. You know, when we open an office, from the word go, our schedule is full. We're packed full of patients that need dentistry. And if there were enough dentists to see all of those children, you know, I don't understand why we would be so busy. We treat these children like family. They are our family, and we're proud to be part of their family also. And we provide high-quality, appropriate dental care to them. You've heard other dentists testify today to the need and the necessity to provide maximum treatment for those children. That's a fact, and there's times when treating those children is a matter of life and death, and Dr. Tran and I are proud to be associated with our dental offices in the opportunity to provide that high-quality care to those children that means so much to them. Cool Smiles, in my opinion, has a world-class clinical and compliance program. It's overseen by two pediatric dentists. The two pediatric dentists, myself and Dr. Walker, are board-certified pediatric dentists. Dr. Walker is recognized nationally as an expert in the field, and we are very confident of the level of care that we provide. And we open our doors. We welcome anyone to come in and take a look at our quality review and compliance program. I'm done speaking. I'm going to turn it over to the people that matter the most. We are honored with the support of the family that's shown up, kind of in the back of the room, and by the fine folks that are standing here today. They promised me there's 4 of them that are going to speak, and they're going to be very brief. But they've driven from Valdosta, Macon, and from Columbus. And I'm going to...
Dr. Strange,
yes,
I
sir.
have one quick question. I'm not sure what the format is. You know, we have 5 minutes, but I don't know if people have signed up, that's fine. But one quick question. Can't remember the dentist that testified earlier said 300 dentists provided 80% of the care. I would assume, or would you assume, that your group of dentists would be in that 300?
Actually, sir, as far as significant traditional providers is concerned, of all of our dentists in our company, we only have 4 providers that qualify as significant traditional providers, including myself. And being here to testify today, I'm not in my office treating those children, so there's 3 treating children for an army of 40 dentists right now.
Well, I'm referring, what I understood him to say was that as it relates to Medicaid, with 300 dentists provided 80% of the service. I would assume your group is among that 300.
Excuse me, Mr. Chairman. The significant traditional providers, it's sort of a confusing concept. It's a very specific list that was taken from 2004 prior to the letting of the contracts. So while we have 4 dentists that are on that list, we have another 51 dentists that all they do and all they have done is Medicaid and Peach Care. And yes, I would include them in that 80%, but no, they're not considered significant traditional providers because they weren't on that list in 2004.
Okay, thank you. Excuse me, Chairman Goggins has a question.
Let me ask you this, any of you. Dr. Smith made a comment a while ago that Help a Child Smile, which is a large provider, where they were negotiating to get back to seeing kids now. Are y'all in negotiations to do this also?
No, sir. We have made a proposal. We offered to take 8% less in fees than all the other dentists take and offered to cap our services. But that was considered by WellCare, who said that's not good enough and please come back and give us another proposal. But we declined to bid against ourselves and just said, please tell us what you need from us, and we never heard a response. In terms of Peach State, we've never heard a response from that proposal.
I'm sorry, say that again.
In terms of Peach State,
you're negotiating a lower rate?
Yes, sir. We were willing to take 8% less than all the other dentists in the state of Georgia are paid by WellCare and Peach State, and we were also willing to cap our growth, basically put ourselves in a subcapitation program, simply because we understood they had a need to be able to predict our growth actuarially, and we never received. Well, WellCare did genuinely consider it and said that's not enough, but wanted us to bid against ourselves, and Peach State's never responded to that proposal.
Dr. Help me understand what you said you was going to introduce who is. We got other people signed up to speak.
We have 4 moms who promised that they're going to limit their testimonies to about 30 seconds each in respect for time.
Because we do have people signed up to speak in front of them.
Well, my name is Shamika McGee, and I have 3 children, 3 boys, school age, that are 10, 6, and 4. They're all Cool Smiles patients. I came to Cool Smiles after seeking child care, or dentistry, for my now 6-year-old child. He was 3 at the time, and I was referred to a dentist's office in Peachtree City, which was approximately an hour away from where I live and very inconvenient at the time. At Cool Smiles that I found, they were able to see all 3 of my children. They had later hours so that I could get my children in to be seen. I'm a single parent who works multiple jobs, and so it's very difficult for me to take days off to make sure that my children receive proper dental care. So I appreciate being able to have their service open so that I am able to get my children in after work hours and also on the weekends. Thank you.
Thank you. Next.
Okay, my name is Magneta. I'm from Ghana. I have 4 kids with Cool Smiles. They love Cool Smiles. The reason is when I go with my children to the dentist, all the places are so close that the children don't have free places to play. But with Cool Smiles, they have places to play, places to roam about, and they have little gifts that they give to the children. So anytime I tell my kids, I want to take you to the dentist, they're so happy. But before, when we take them to different clinics, different dentists, they are not happy. That is the reason why my kids like Cool Smiles. So I want you to consider them. Thank you.
Thank you.
Mr. Chairman, in the interest of time and the lateness of the hour, we're just going to decline. But I would like for everyone who attended today, who's been here since 3 o'clock, to please raise your hand, because many of them have driven from Dalton and Valdosta and Macon and Columbus and here around Atlanta. And we think that's a pretty extraordinary representation. And we also want to close with letting you know that our patients, just like these, have submitted over 15,000 handwritten letters to the governor over the last 4 weeks since we found out about these terminations, asking for Cool Smiles to be reinstated to the network. Thank you.
Thank you. Dina Zinka. Beth Spotto. And that one is Sally Sage here. You after her. Well, plus
I'm going to be real brief. I'm going to talk about money. My introduction says, good morning, Chairman Chanel, and I was being optimistic. But I appreciate the opportunity to speak. My name is Elizabeth Spoto. I am a managed care consultant and president of Spoto & Associates. I represent in the range of 10 to 14 rural hospitals in the state of Georgia, throughout the state of Georgia, and I'm here to talk about some key issues impacting on those small hospitals that in almost every case the hospital I represent is the only hospital in its community. And they're small, 50-bed, 60-bed hospitals. The top issue that I would bring to your attention is the payment of ER claims by WellCare of Georgia. There are some things that I am very impressed with WellCare and their operations. However, the payment of ER claims is not one of those. I don't want to frame this financially for you because you've asked questions about financials and you've asked questions about financials. The way a lot of these contracts were done, without giving away specifics, is they were meant to model the way the state paid the provider, which if you are a regular hospital versus a critical access hospital, 85% of your cost. So understand that the top amount of money you're going to get is less than your cost. In the ER, for urgent care claims, you're going to get 85% of your cost. With the exception of non-urgent claims, they get paid $50. Let me put some dollars around this, okay? Typical charge for ER at a rural hospital, $600. Typical determination from audited financial reports where you get 85% of your cost, you get $200 on that $600. So we've got a $200 average payment versus a $50 non-urgent payment. Prior to go live with the state of Georgia, it was very typical for my clients to have non-urgent claims, the $50 amount, from anywhere from 20% of their ER volume to 35% of their ER volume. So they all expect non-urgent patients and they understand the $50 charge. There were discussions that WellCare would pay the same way the state paid. Well, what has happened, if you look at the percent paid at the $50 level, in surveying my hospitals, it went from anywhere from 20%, 35%, it's doubled and tripled. Okay? So you've gone from a fourth or a third of your business paying, of your ER business paid at $50 to all of a sudden 3/4 of your ER business is paid at $50. And that is not anywhere close to 85% of your cost. That's not 50% of your cost, okay? So you're talking about a differential of $150 per case. Now, I'm throwing that out as a hypothetical, but I have seen those numbers with typical hospitals, okay? ER revenues make up 33% of Medicare revenues. WellCare of Georgia has 2/3 of the Medicare population. You're talking about tens of hundreds of thousands of dollars. So when you say, how can somebody pay less than what the state pays for critical access hospitals, when you flip those numbers, and ER is such a high volume service, it's real easy to get there. Okay? On top of that, you're talking about less payment, and then I want to bring up a point that a representative talked about is increased cost. The cost to file a clean claim, according to an old HFMA study, was $42, $43. That's a clean claim. We've got to appeal all of these claims to be paid. When you have to appeal a claim, you've got to get nurses. You've heard about all these hospitals that had to hire additional people. Our rural hospitals are no exception. It cost over $100 to get an appealed claim paid. So you can understand that our reimbursements have gone down 10, 15%. Our costs have gone up. And we really have not seen an immaterial decrease in ER volumes. So that's the number one point I would want to bring to your attention. We have had issues with all of the payers in getting most of the rural hospitals I represent are the rural health care providers in the community. They employ the docs with rural health clinics, hospital-based clinics. We've had issues with getting them set up and straight. I literally just last month got 2 clinics fixed I have been working on with the payers for 12 months, where we're owed money back from September 2006. AmeriGroup, which was paying us fine on hospital-based facility payments, sent one of my clients a letter out of nowhere saying they weren't going to make the payment anymore. This is not a unique structure. Medicare pays it, Medicaid pays it. I haven't gotten anybody to return my call to discuss it. We have issues with Peach State implementing new pre-cert referral processes in the last month, where all of a sudden clients are having to initiate referrals and pre-certs. They're not getting timely turnaround. And they're, in fact, when they're getting the referrals and pre-certs, they're submitting the payments to Peach State, and Peach State is actually denying them even with the referral information on the program. It could be an operational startup issue, but I've been on phones with providers trying to get this fixed again and again and again. So there have been some good things with the implementation. I applaud a lot of the things Kathy Drigger's office has done, but I will tell you the number one revenue issue right now is the ER.
Sandy Sage and Tom Meadows would be next.
Hi, thank you for allowing me to speak. And you all have my detailed speech, so I'm going to make this really short because we've all heard about the issues. I'm one of the nurses that does the appeals on the ER triage payments that you've heard so much about today. First of all, let me say that I'm from Fairview Park Hospital in Dublin, Georgia. We're an HCA facility. At this time, we are receiving the $50 triage payment on 80% of our WellCare ER patients. As the clinical person that does the appeals, I review the charts, I write the appeals, I send them in, I follow up, and we're overturning probably 50 to 60%. But our problem is the inconsistencies in WellCare's payment. First of all, we don't know what they consider emergent. I've seen patients in motor vehicle accidents with their bills up to $5,000, $6,000 in the emergency room paid at the $50 rate. I've seen children with a cold paid at the emergent rate. So there's really no consistency. There's no consistency in our appeals. I've attached on the back of that a spreadsheet for you. I've tried to make sense out of how they pay the appeals because I thought, if I know what they're going to pay, then we can minimize what we appeal, because if there's some consistency, I'll just appeal the ones that we know they're going to pay, but there's been no consistency. So let me just tell you about 2 cases, and then you have a few more on the back. In the first case, a 9-year-old child fell off some playground equipment and hurt his neck. The second, a 12-year-old child did a backflip doing gymnastics and landed on the top of her head, and she was complaining of neck pain. Both children were brought to the emergency room, and both children were paid at non-emergent rate. As a clinician, as the ER doctor, of course that's emergent. The child could have had a spinal injury. Fortunately, neither did, but since at the time that they presented to the ER it was an emergent condition, I went ahead and appealed the cases. The result, the 9-year-old who fell off the playground equipment was paid at an emergent rate. The child that had landed on her head doing gymnastics, that was denied, and we only received the $50 payment. So these cases were so similar, I'm having difficulty determining, what to appeal because there's no consistency, there's no rhyme or reason. Another case, there were 2 pregnant women. Both came in complaining of abdominal pain. Anytime a pregnant woman comes in and has abdominal pain, you are concerned about premature labor. Both were evaluated and referred to their OBGYN. They were stabilized. Both of them paid at the $50 rate. I appealed both cases. One was paid at an emergent rate and one was not. And the cases were very, very similar with no noticeable difference in their treatment or in their symptoms. And so we would like some kind of continuity, some consistency in not only our payments but in what they pay on appeals. And we are not seeing that with WellCare. And it's almost a full-time job appealing all the $50 triage payments, and we'd really appreciate your intervention in this case.
Who you appeal it to?
Pardon?
Who do you appeal it to?
I make a copy of the chart. The WellCare has a form. I write out what I think made the case an emergent case and send it to WellCare, and they'll send it back to me. Sometimes I don't agree with the fact that they're not going to pay us anymore, so I'll send it back. Their medical director will review it, and the medical director is just as inconsistent on the second appeals as they are on the first.
You appeal it, what is WellCare or any of the other?
Send it to their appeals unit in Tampa, Florida.
But they turn you down, and then you send it to them to appeal it.
To look at it again. Well, when they denied it the first time,
is that correct?
When they denied it the first time, they're really not denying it, and that's how they could say the denial rates are so low, because they're paying it, but they're paying it at a non-emergent rate, so it's really not a denial. So what they request that you do is send the record so they can see if they really need to pay you at an emergent rate.
But who does the medical director work for who determines the appeal?
WellCare. But there are no guidelines as to. And then if WellCare denies it the second time, we send it to WellCare again, the third time, and we just hope that one day they'll pay.
Okay. I'm sorry, I'm not laughing.
No, that's
at
right.
you.
We don't have any other options.
I would assume you're not going to win many of those appeals, but Representative Gardner.
Is there any process for an independent appeal if WellCare, who pays medical director,
no,
denies again, and there's no other place for you to go?
They say that if you appeal twice, then you can go to an administrative law judge or something. By the time you went to an administrative law judge, you've spent so much money during the appeal that the amount of money they're going to pay you anyway isn't really going to make a profit for you. Thank you.
Thank you. Tom Meadows. Kathy Whitmire is taking Mr. Meadows' place.
Thank you, Chairman Chanel and Senator Goggins Committee. My name is Kathy Whitmire. I'm with Hometown Health, where I serve as Managing Director for Hospital Services for 56 rural hospitals here in Georgia. Tom Meadows had to leave. He had a need to be home before midnight tonight. I won't say emergency, but he was the CEO of Miller County Hospital and drove from Colquitt, Georgia today to make one main point. And his point was, as a result of the impact of the CMOs, along with the decreased funding of the Indigent Care Trust Fund this year, he's been forced to close his largest rural health clinic in Early County. He has eliminated all of his OB, his delivery services, and nursery service offerings at Miller County Hospital. He's reduced his surgical offerings to day shift only, Monday through Friday. And absent some resolution of this funding problem, he fears the continued existence of the hospital and their nursing home that serves the residents of Colquitt County. So I submit that, and that copy is inside the folder that I just passed out, all the copies that he provided. And I would just like to summarize a few of the comments. We're not going to duplicate, but I come on behalf of the rural hospitals in Georgia, 35 critical access hospitals, and 28 of the 35 critical access, and the rest under 150-bed hospitals. The key points that we want to make today is that Hometown tried to circumvent this complex implementation of these the CMO platforms with over 3,000 training hours via online training weekly to all the hospitals. This was available to all hospitals in Georgia. We established a work group that met with each of the CMOs to identify the top 10 implementation issues and set timelines to work through those. Those issues are also in the folder. But there are still so many problems in the system, and the net of it boils down to the reports that we do show that the CMOs pay clean claims at a high percentage rate, but they do not report the underpayments, the pending claims, and the total denials that prevent the cash flow. Basically, our rural hospitals, it's an undue burden to them. You've heard this appeals process is unbelievable. And to add on top of that, it's not electronic. It is paper. The paper remittances, if you can imagine managing appeals on thousands of claims on an Excel spreadsheet and with paper remittances and submitting documentation by paper and tracking it. And this is one person in a UR case management role in a rural hospital. It's impossible. So the main point is all boils down to, with the manual process, the CMO wins. And the rural hospitals default by their inability to track this process and maintain and manage the appeals. So the undue burden basically it brings our hospitals to the point that our county is today, along with many others. The utilization reduction through the physician screening and the case manager model, it did not work. The gatekeeper model is not working. The physicians are not able to screen and manage the tremendous populations that they are having to manage, because in some areas we have one family practice managing. Their panel is supposed to fill at 1,500 patients. But try telling those patients at 5 o'clock that you can't see them today because you can't just work another minute. So what happens is that they send these patients to the emergency rooms. There is virtually no case management for these sick people in rural Georgia. I have called all 56 of our hospitals, and I can't find one example. The lack of physician access and the inability to screen the patients drives the patients to the ER. And the burden is, EMTALA says that we have to take all comers. We cannot reject any patients in ERs, especially when it's the only place of access. The CMO has total control in the ER of the payment. So arbitrarily and inconsistently, they use the prudent layperson language concept to declare almost all, and you've heard, over 80% of the claims non-emergent, and they pay the $50 triage fee. But our hospitals have no manpower and no recourse to appeal. They don't have the overhead to continue this process, so they default. The CMOs win. The state makes it $78 million savings, which is not what the state was supposed to be purchasing. The result is that our providers, they have no say-so in how these patients are presented to the ER. They have to take them and take the $50. This has devastated all of our hospital systems, and it's evidenced by the exit of OB delivery. And I'm not sure if this was not stated today, that 33 of our 35 critical access hospitals in Georgia have stopped OB services. There are only 2 critical access actually delivering babies, and that is directly due, in my knowledge, in the last year, of 5 of these hospitals directly related to the CMOs. Of course, the doctors have been lost, and there's a tremendous reduction in health care. So in closing, we've laid this out. We've laid this out to all of the CMOs individually with the very top executives who are most of them are here with us today. We've laid it out to DCH with no results. And I'll give you the results of the meetings that we've had in the past 6 months or 3 months with DCH, with WellCare, just so that outlines the facts and all the details of the top issues. So we just ask you to we submit all of that information and ask your favor and consideration in considering these rural hospitals in Georgia. Thank you.
Thank you very much. John Williams, followed by Fred Turpin.
Good afternoon, Mr. Chairman and members of the committee. My name is John Williams. I'm the Chief Financial Officer at Upson Regional Medical Center in Thomaston. And I'd like to share the financial implications of the Medicaid care management organizations at our hospital. Upson Regional Medical Center is a 115-bed sole community rural hospital provider for a 7-county area in west central Georgia. We're one of the largest employers in our community. We employ about 600 citizens. The Medicaid utilization in our medical center represents 19% of our business, and I've included an exhibit to reflect the payer mix in our hospital and also to highlight that the uninsured utilization is 12% of our business also. You've heard the number of issues, and I'll not go into that, but we have experienced the same. And with this, with all the numerous process issues, access of care issues that's been described today, we wanted to review the financial implications since our June 2006 implementation. So we looked at the traditional Medicaid reimbursement from the period January 1 to May 31 of 2006. This is the pre-CMO implementation period. Compare this to the January 1 of 2007 to May 31 of 2007. So after we had been in it for almost a year. I've got a second exhibit that reflects during the 5-month period in 2007, we had a reduction of approximately $386,000. On a per count basis, this represents a reduction of $54 or 10%. I think you've heard those numbers today. On an annualized basis, this represents a reduction of approximately $926,000. Please keep in mind, and you've heard that again, please keep in mind that Medicaid only allows 85% of costs to begin with for hospital outpatient services. And the outpatient services account for 62% of the Medicaid utilization in our hospital. Therefore, the 10% reimbursement reduction equates to approximately 77% of costs reimbursement by the new Medicaid CMO program. So as you can see, we started with a 15% loss for providing Medicaid services and now experience a 23% loss for providing the same services due to the many issues that are being shared with you today. This only exacerbates an already dismal picture for any hospital provider in Georgia, but especially to those that provide 31% or more of their business to Medicaid and to the uninsured population. In response to the Medicaid CMO reimbursement reduction, our hospital salaries for 2007 are being reduced by $939,000 or approximately 20 FTEs, somewhat different than what you've heard with other people adding staff. We have redeployed staff for appeals process. But knowing the impact that we've had, we've looked at our staffing and are adjusting downward as well. So given that we're one of the community's largest employers, this negatively impacts employment and taxes on an already economically depressed area of the state. So with improved staffing efficiencies that Upson Regional realizes now, any other cost improvement opportunities to offset additional reimbursement cuts will be minimal, short of discontinuing services and forcing beneficiaries to drive long distances to get treatment. The information that I'm sharing today represents only one hospital in the state of Georgia. I'm sure that each one of the other facilities could present similar information to reflect their own negative financial impact as well as their own system process issues, and could underscore that the savings realized by the new CMO program are achieved solely by forced reimbursement reductions instead of better case management of the Medicaid population. I understand that you'll be hearing reports from the CMOs tomorrow. I'm sure that reports will be presented that reflect the health care services are provided as needed, problems are addressed timely, and that the medical loss ratios are so high that CMOs are probably losing money. With this in mind, Upson Regional would welcome any committee members to spend a day or two at our facility to speak with our physicians, our hospital case managers, our hospital billing staff, to learn more about the real impact that the care management organizations are having on our local healthcare delivery system. So I respectfully ask that you strongly consider the provider testimonies being heard today so that the negative implications can be properly addressed and resolved in a timely manner for the good of Georgia's future healthcare delivery system. And I thank you for your time and for extending the comment period in this late afternoon.
Thank you very much. Fred Turpin and Faye Brown. Faye Brown.
I'm going to be like the CMOs and reduce some of my comments so everybody didn't have to listen to them. A little light humor there for everybody. Mr. Chairman, members of the committee, thank you for allowing us to attend today. My name is Fred Turpin. I'm a 28-year active practicing doctor of optometry with offices in Albany and Dawson, Georgia, Representative Hanna's area. We're located in the 2nd Congressional District, which is probably one of the poor areas of the United States. Therefore, there's a large majority of Medicaid patients there. In my Albany office, I do take, I'll call the old Medicaid and WellCare. In my branch office in Dawson, I do take WellCare, old Medicaid, and Peach State. I'm also the liaison for the Georgia Optometric Association. In 2006, the VISUS was awarded the contract for all the services provided by Georgia Doctors of Optometry, both refractive and medical, for Georgia Medicaid patients enrolled in WellCare, AmeriGroup, and Peach State. Then in July 2007, everything changed for optometry and our Medicaid patients. We were informed with 2 days' notice that a VISUS would no longer handle medical eye care, but would only cover routine refractions and eyeglasses for WellCare and AmeriGroup. OptiCare, which became the child of Peach State, would be providing their own refractive and medical care for their own patients. As Medicaid providers for both refractive and medical eye care, we were advised that we must be credentialed directly with WellCare and that AmeriGroup would be accepting our existing credentialing provided through VISUS. It is worth noting, until this decision just last month, I was providing both medical and refractive care for Medicaid patients enrolled in WellCare. When I requested credentialing information from WellCare, I was advised that WellCare would not credential me because I was not an MD. Then after WellCare was made aware of the Patient Access to Eye Care Act passed in 1997, they decided to reconsider and sent me a contract. The contract was at 90% of the state-mandated old Medicaid reimbursement formula. We questioned them about that, and they said that's the best we can do. I spoke with a friend of mine that's an ophthalmologist in the area, his office staff, not him directly. They're reimbursed at 102%. So we didn't think that was quite legal through this whole process. I emailed them back. They said basically live with 90%. And as people have mentioned before, the rate has not been increased since 2002, I think. WellCare does seem to be more receptive after the dental issue has been brought to light recently. And I think we do have a meeting scheduled with them on September the 5th, which is next week, to discuss some of these issues. As the other groups, we have financial issues. The most they will pay me is $40 for a routine eye exam. We've already up to $40 by the time I even see them. Patient cost, the chair cost, the light bill, just getting the people there, paying my staff. I'm already at $40, and I'm losing money by the time I see these people. And we've tried to get that fee up, and we've to no avail at this point in time. Also, under one of the contracts, I think it was Peach State, or both of them and WellCare, may also have a statement that says within 30 days that patient has to be seen. Are you aware of that, Ms. Triggers? My staff has told me if I abided by that rule, 90% of my practice would be Medicaid. I can't afford to do that. And what would I do with my other patients? And they're doing the, what do you call your shopping calls to the offices to see if we're abiding by those rules. Therefore, I dropped Peach State from my Albany office because I could not abide by those contractual demands. I went on the Peach State website last week because my Dawson office does take Peach State, which is a very small community. There were no listed eye care providers in Albany, Georgia, which I'm not sure how many people are on Medicaid in Albany, but the population is around 100,000 people total. I'm not sure the exact Medicaid number, but I'm sure it's significant. But there were no providers. We also have the lack of uniform claim submissions that the other people have had to deal with. But as a Georgia taxpayer, I'm pleased that CMOs are saving money. It's $78 million, $248 million. I'm not real sure what the exact number is. But if they're saving this much money, why can't they reimburse the providers a little more money? I think the state legislature needs to address that issue. The CMOs must be making money or they would not be after the final piece of the pie, the blind and disabled. And I certainly hope that they stay under the old Medicaid because these poor folks aren't going to be able to make it under the CMO structure. As a doctor of optometry, I felt an obligation to help mankind, but when I'm forced to accept significant fee reductions, a limited drug formulary, and excessive exam and appointment requirements, it surely makes one wonder why I should continue. In conclusion, I think the CMOs need strict oversight. I've come to the conclusion that they do what's in best interest for themselves first, the patients, then the providers are last on the list. I have just one final last comment, and I think this is how the CMOs see themselves and how they work and how they make money. They reduce services, they use an antiquated drug formulary, they continue to reduce the provider network. These simple steps equals more money for the CMOs. One final comment, and I'll be through. The total numbers for Georgia optometrists on the state board record per Georgian is approximately 1,350 licensed doctors of optometry, and approximately 350 are in the Medicaid program. Thank you very much.
Thank you. Faye Brown. Faye Brown. Steve Payne.
Good evening. Thank you for the opportunity to speak to you. I'm here as the father of a patient. In May of 2003, my daughter was diagnosed with 2 rare forms of juvenile rheumatoid arthritis. She was 22 months old. A lot of people hear arthritis and they think, oh, it's just a little pain in the joints here and there, but it's a little bit different for her. One form can cause her to go blind. The other form, which is systemic onset, means it's not confined to one area of her body. It's all over. And it can attack her organs also. It can kill her. She was not able to turn herself over in the bed, hold her own sippy cup. She was in excruciating pain constantly. We went through all types of medication trying to get her better. There's also what's called a JRA fever that's associated with the disease. It would spike at early in the morning, 3 o'clock in the morning. She'd be running 105-degree temperature. About 10 o'clock in the morning, she would bottom out below normal. And there was also a rash that was associated with it. After about a year, she was on steroids, immune system suppressants. The medications themselves were toxic to her. They could kill her on their own. After about a year, we got her on what's called Enbrel, and it has been a miracle. You look at this child today, and you can't tell there's anything wrong with her. Under Peach Care, we had no problems getting this medication. Never. June of last year, when it changed to Peach State and WellCare, she went under Peach State. Peach State denied her medication. They said it wasn't suitable for a child. Now, her doctor had prescribed this medication for her. She had been on it for 2 years. And if it had not been for our local pharmacist, Mike Miller, she would have gone a month without this medication. But he took it upon himself to provide her with this medicine with no guarantee of getting paid back for this medication. And this is very expensive medication. It costs about what I make per month for her to have it. It's an injection. It's given to her twice a week. It comes in an adult dose, and that presented another problem with the insurance company. That was one of the reasons they said she couldn't have it, was because it wasn't suitable for a child. But there again, her doctor had prescribed it for her, and it was working. It had been working for 2 years. I know you can't see these pictures good, but this is her today. This is her before Enbrel. From the steroids and the immune system suppressions. You can't treat a child by looking at paper. They tried to take the treatment of my child out of the doctor's hands. When I was on the phone with them, they told me I was not a doctor. And that's true, I'm not. I'm a parent. But I'd do anything in the world for my child. And the doctors had prescribed this medication for her. Well, after fighting on the phone with them myself, my pharmacist fighting on the phone with them, a member of my church got involved, and he contacted the governor's office, and through that, we finally got the medication approved. But they wanted to change that also. Once they approved it, they wanted to send it to the doctor and have the doctor administer it to her. I had been giving her these injections for 2 years myself. Her doctor was 45 minutes away. There was no reason for that to happen. Well, I'll try to be brief and wrap it up. We finally got it approved, and now it comes to me by mail, and that's my last concern. This medication has to be refrigerated. It comes to me packed in a styrofoam cooler. Sometimes it's got one cold pack in it. Sometimes it's got two. You never know. There's no way of checking the temperature inside the cooler. It arrives at my home when I'm not there. I'm at work. And as you well know, we've been having extreme temperatures that's sitting out on the porch. I'm very concerned about the temperature of the medication staying beneath where it should be. I don't understand why my local pharmacist cannot supply me with this medicine. He was doing it for 2 years before the insurance plan changed. He cares about my child. He knows my child. You know, we need our independent pharmacists, our local pharmacists. I don't understand why we're trying to put them out, and because they care about our children, you know. These mail order companies, they're out for the money. They don't care about my child. They've proved it. So I ask you today to please consider making the changes in this plan that need to be made to make sure our children are taken care of, because that is the bottom line. That's what this program is supposed to be all about. Thank you very much.
By my count have heard from 72 people today, and I'd like to thank the members of this two subcommittees and the people who aren't on this subcommittee in the General Assembly for being here. I certainly would like to thank all of the people from across this state who took time out of their personal life and business life and professional life to come here and share stories with us today. It's been a long day, but we've learned a lot. I think it's probably fair to say that although we're just about a year into implementation, we probably still have a little work to do before we get this thing where it's acceptable to us as legislators and the people in this state. In 14 hours and 50 minutes, we'll be back in here, 9 a.m., and we will hear CMO's take on this. Again, thank all of y'all, and Chairman Goggins, do you have anything to